All right, I think we are all here in Las Vegas.
Thank you very much. All right, good afternoon, everyone. This is the posted time and place for the Silver State Health Insurance Exchange meeting, which has been properly noticed for today, Thursday, November 8th at 1 p.m. Our meeting is being video conferenced between here in Carson City at the Legislative Building and also Grant Sawyer Building in Las Vegas. We also have one of our board members on the telephone with us, joining us from another location. So with that, I am going to turn, well, before I turn it over to roll call, for those people that are on the telephone, if you would not mind muting your line unless you are speaking. And also, please remember, please do not put us on hold, because many times that puts a music factor on the backside that we can hear. So I would appreciate that very much. This afternoon we are also going to have the workshop for the first of the regulations that the Health Insurance Exchange will be adopting, and that will be conducted in just a few minutes after we get through with public comment and the approval of the minutes. So with that, I'm going to ask Mr. Hager if he would take roll call, please.
Ms. Atkins?
Here.
Ms. Lewis?
Here.
Dr. Klein?
Here.
Ms. Kerr?
Here.
Dr. Ford?
Here.
Director Wilden?
Yes.
And Director Breslow is absent. He will probably be with us at the next meeting. Director Molenkamp?
Here.
Vice Chair Johnstone?
Present.
And Chair Campbell?
Here.
And we have a quorum, and I would like to point out, you might have heard that new name. Director Breslow is the new Director for Business and Industry. I believe Director Johnson is now with the Gaming Control Board. The three director positions are ex officio positions. They are the directors of Health and Human Services, Administration, and Business and Industry, or their designees. And so that's why you see the change in the membership for Director Johnson becoming now Director Breslow for our board.
Thank you very much. John, do you have any other announcements for us today?
Not at this point.
Okay. Then I'm going to open up agenda item number 2, which is public comment. And Ms. Johnstone, would you help me with that down in Las Vegas, please?
I don't see anyone coming forward here.
Thank you. Is there public comment here in Carson City? If you'll come forward and identify yourself for the record, please.
Good afternoon. My name is Joanna Jacob with Ferrari Public Affairs, and I'm here on behalf of DaVita. Thank you for the opportunity to give public comment today. I'm here to address recommendation number 8 out of the Plan Certification Subcommittee regarding network adequacy standards. The ACA requires, in order to be certified in the exchange, that a qualified health plan have a sufficient choice of providers. Then that was further clarified in federal regulations that after comment that was received, that services must be available without unreasonable delay. However, like so many other things, the federal government left it up to the states to define what unreasonable delay means. So DaVita is asking the state to adopt a network adequacy standard for patients who are requiring dialysis. We believe that in metropolitan areas like in Las Vegas and in Reno, that a drive time exceeding 30 minutes to access treatment would constitute an unreasonable delay, and we're asking the state to adopt such as a standard. Recognizing that might not be feasible in our rural areas in the state, with regard to those areas, we're just asking that a sufficient standard be adopted, working with providers and patients in that area. DaVita has 22 treatment centers in Nevada, including one that recently opened in Winnemucca. And we're very interested in being involved in the conversation about network adequacy standards in the state. I understand that the exchange is working on this with the Division of Insurance and the Health Division, and we intend to submit comments to both those agencies as well. We've submitted a letter for you for public comment today, and we've addressed those concerns in that letter. So thank you very much.
Thank you. If you have written comments that you want to turn in to Athena, we gladly accept them. Is there someone else here for public comment? Yes, if you'll come forward and identify yourself for the record.
Good afternoon. My name is Nancy Hook. I'm the Executive Director of Great Basin Primary Care Association. Our members include the community health centers, tribal health centers, and other safety net providers. We'd just like to say that we support recommendation number 8 as well, and look forward to the opportunity to work with the division, the health division, in working out the details. That's it.
Thank you. Nice to have you here, Nancy. Any other comment here in Carson City?
Madam Chair, the public comment from the representative from DaVita is on our website, so if anybody wants to see that, the written documentation is available at the bottom of the November 8th meeting page.
Thank you. Is there anyone on the telephone that would like to take advantage of public comment? Hearing none, I'm going to close the agenda on item number 2 and open item number 3, which is the approval of the October 11th Silver State Health Insurance Exchange Board meeting minutes. Do we have any edits or additions or corrections to those minutes?
Madam Chair, can I just have a moment, please?
Yes.
May I ask a question? Mr. Hager, on item C, 7C of the minutes, none of this is showing approved, correct?
For the record, John Hager, sort of. For agenda item number 7C, which is the consumer assistance piece, there were 2 recommendations. One was for the plan for navigators, producers, and outreach specialists, and the other was regarding web-based brokers. The board approved the committee's recommendation to not allow web-based brokers to provide, to enroll people in qualified health plans through their web-based systems. However, you are correct. On page 4, you'll see the motion. It's the first motion, which is in the middle of the page, on page 4, to defer the plan for the navigators, producers, and outreach specialists to update the document with the proposed changes. And so there was a little bit of confusion about this. It's a perfect opportunity. We brought back the budget for the navigators in a later agenda item for today. We did not bring back the plan. That wasn't because we were trying to delay it. We simply forgot about it. If you recall, we went through a whole process of discussing which sections to approve and to not approve. And then after we got through that whole process, we said, let's just defer it till the next time. So my mistake for not including it here. We will include it either at the December or January meeting. We were trying to keep the December meeting short. However, if it is concerned, we can include it in the December meeting. It's up to the chair and the chair of the Consumer Assistance Committee when they'd like that heard.
Thank you, Mr. Hager. I just wanted to make sure we were on the same page with that. And my preference is that it comes up on the December meeting. But other than that, I don't have any changes, and I'd be more than happy to make a motion on the minutes. I move that they be approved.
Yeah, this is Dr. Klein. Can I ask one quick question on 7C again?
Yes, go ahead, Dr. Klein.
Yeah, my understanding is that we did not agree that navigators would be certified by this is sort of along the same lines as Ms. Atkins, that they would not be certified by the Division of Insurance and compensated by the exchange, that they actually could be compensated by other groups. So I think that whole recommendation 4 really was not approved. C4.
Dr. Klein, this is
C recommendation 4 was not approved.
For the record, John Hager, that is correct. Dr. Klein, the entire recommendation was not approved. We were going to go back and update it. Specifically regarding the idea that navigators are paid or not paid by the exchange. When we went back and reviewed the regulation regarding navigators, it says specifically that they are paid for by the exchange. However, it doesn't give you a minimum dollar amount, so they could be paid $1 and be paid for by the exchange. So we do need to go and look at that again and come and massage it a bit and bring it back to the board.
So maybe you would just modify the minutes to remove recommendation 4 as having been approved.
The recommendation number 4, the middle of page 4, it says to defer to the next meeting and ask staff to update the document with proposed changes.
Okay.
That motion refers specifically to the plan for navigators, brokers, and outreach specialists.
Okay, great. Thank you.
You know, and Dr. Klein and Ms. Atkins, I think the other thing that is easy to look at is in the minutes, recommendations 1, 2, and 3, they actually give the date on when they're approved. So because the minutes don't reflect a date of approval on recommendation 4 and 5.
Well, so this agenda item, when it was provided at the October meeting, would not have had a date they were approved because they weren't approved at that point. So when we go back and include them in a future agenda, we will include the approval date in that item.
All right. Does everyone feel that the minutes are accurately reflecting the activities of the October meeting? We have a motion by Ms. Atkins, and I'm sorry, I didn't hear who gave the second, if there was one.
Marie Kirsten wasn't the second. Well, I second the motion.
All right, thank you. We have 2 seconds on that, by Ms. Kerr and by Ms. Lewis. Any further discussion? All those in favor of the motion?
Aye.
Aye.
Thank you very much. All right, the motion is approved. We'll close agenda item number 3 and move to agenda item number 4, which will be conducting our first workshop to solicit comments on the first regulation for the initial administrative code to chapter 695I of the administrative code. So I'm going to turn it over to you, John, to get started. Hopefully we will have a lot of interaction on this if we need public comment. As we are moving through the workshop, if there are interested parties in speaking about a particular section of the regulation, if you would come to the testimony table and we will recognize you as we go through the regulatory process. Thank you. And Mr. Hager, if you want to get started.
For the record, John Hager, as Chair Campbell indicated, this is our first workshop for regulations. You'll notice that the regulation says to amend NAC 695I, so Nevada Administrative Code Chapter 695I. It says amend, but that chapter does not yet exist because this is the first regulation for that chapter. So you can think of it as a blank book for which we are putting the pin down initially. Obviously, the purpose of this discussion is to create a regulation regarding charging fees to the carriers pursuant to previous board action. There will be several groups of workshops. So this workshop is in regards to the specific regulations that are provided in Attachment A. And then there will be an adoption hearing in January. The adoption hearing pursuant to the board's recommendations, the board approved policy, we have a 15-day notice requirement for the workshop, which we fulfilled 15 days ago. So this is the workshop. We're going to go over the language, massage it a bit, take all the comments that we have, and make sure we've got proper language. And then there's a 30-day notice requirement for the board meeting. As I discussed earlier, we're trying to keep the December board meeting down so we can keep it to a phone meeting and give people a little bit of time to catch their breath for the holiday season. There are a few things that we will have to have in December, but we're going to avoid the workshop and regulations for that month. So January will be the adoption hearing for this regulation unless there's another workshop required. If there are substantial changes to this language, we will have to have another workshop. Whether or not it happens at a board meeting or not, I think recommendations of the administrative manual is that they happen concurrently with a board meeting. We can decide what we need to do when we get to the regulation and if there are changes to it. There will likely be several additional sets of workshop adoption pairs that will be later on. Probably in January we will have a workshop after the adoption hearing. We'll probably have a workshop for plan certification processes that will then have a workshop an adoption hearing for that in February, and then we will also likely need an adoption or a workshop adoption pair for appeals, and then a couple of things for enrollment. We're still working through some of these things with our IT vendors and with the Division of Insurance, and trying to determine, and with our DAGs, and trying to determine exactly what requires a workshop or a regulation and what doesn't. So that's kind of how we're moving forward over the next several months. So we start off on page 2 with the authority and what we're doing here. Because this is new, we wanted to make sure we laid down a proper groundwork for the adoption. And as we've discussed several times, the exchange is exempt from the Nevada Administrative Procedures Act, but the statute for the exchange, NRS 695I 370, allows the board to adopt regulations to carry out its duties. The procedures that are generally followed in Chapter 233B, the board, of course, decided that it wanted to follow them fairly closely. So we have drafted the regulation. We have submitted the regulation to the Legislative Counsel Bureau. We provided a small business impact statement. This is the workshop. We will issue the notice of intent to adopt regulations at least 30 days prior to the January board meeting. We'll have a public hearing during that meeting. It's basically a board meeting that has an adoption hearing. So the public hearing, consideration of public comments, and adoption, and then and that will be the final adoption. And we will submit it at that point to the Secretary of State. We have on step 2, submission to LCB. We have talked with LCB legal staff, the LCB counsel, about the submissions. We've indicated that while we would appreciate it if they could review the regulations for any inconsistencies or problems that they might see, that because of the tight timelines, and we understand that they are going through the bill drafting process and they may not have time to get to this, that we are not waiting on their reply. We haven't had a reply for these regulations. We might receive a reply in the next week or two, and we'll make sure that information is provided to the board and the public if we get it. But again, because of the tight timelines, we are not requiring a response from LCB Legal. They are, of course, swamped right now with bill drafting. The other piece that we are not doing is the submission to the Legislative Commission. And again, that is because of the time frames and the fact that they're in the temporary process. And the third change to the normal process is that we are adopting permanent regulations even though we are in the temporary regulation season. The last thing here, final adoption, includes submission to the Secretary of State, and we have confirmed with the Secretary of State's office that they can accept those and file them as any other agency would. So as far as funding authority, the authority to set regulations to charge fees, the exchange is required is required to perform all duties that are required of the exchange to implement the requirements of the Federal Act. And the Federal Act is basically the Affordable Care Act. And the ACA indicates the state shall ensure that the exchange is self-sustaining beginning on January 1st, 2015, including allowing the exchange to charge assessments or user fees to participating health insurance issuers or to otherwise generate funding to support its operations. Furthermore, the exchange was granted the authority to apply for and accept any gift, donation, bequest, grant, or other source of money to carry out the duties and powers of the exchange or board. Based on that information and the recommendation of the board to approve the policy of the Finance and Sustainability Committee to supplement the exchange's revenue by charging user fees for standalone dental and vision products, and then the final recommendation about charging a per member per month assessment on carriers based on enrollment. We have come up with the regulations that we'll be going over. So the regulation options, there are several different ways that you can go about setting fees. Number one is that we could actually create the fee and provide the fee actually in regulation. That would, of course, require that the exchange go through an adoption, a formal adoption process every year, or every 2 or 3 years to create the fee and actually put that fee in regulation. Or the exchange could adopt a single set of regulations that provide the process to create such fees, so that the regulation is changed very rarely, if at all, but that it would give the board the ability to. It would basically set the process for the board to create the fee, and that is kind of how we have gone about the process here, so that there will be basically a 15-day notice. So rather than the 3-day notice requirement of the open meeting law, we will comply with a 15-day notice to charge fees. We'll make sure all the appropriate parties are notified, conduct the meeting to adopt a fee. That the approval of the board during that board meeting would be the adoption of the fee, and would post it on the website at the given time. So that is basically what we've gone through here. So the proposed regulation under the discussion on page 4, you kind of have to go through page 4 alongside attachment A. It kind of explains the different parts of the proposed regulation. So sections 2 and 3 of the regulation define exchange member and standalone. Generally, the use of jargon terms should be avoided in the creation of regulations. However, in certain circumstances, jargon terms may make the regulation easier to read. In these cases, the terms should be defined. The regulation includes several other jargon terms, for instance, board, exchange, qualified health plan, qualified individual, and qualified small employer, that are not defined here, but are included in definitions in NRS, in our chapter of NRS.
And with that, John, I would like to open it up for discussion as we go through some of these sections. Section 2 and 3 really are the only definitions that we have in this new regulation. So if it's if the board does not object to it, I would like to open up for discussion sections 2 and 3 to see if there's any public comment for amendments or changes to either one of those 2 sections. And Ms. Johnstone, do you want to help me there in Las Vegas to see if there's any comment there?
I don't see anyone coming forward, Madam Chair.
Thank you. We do have someone here in Carson City. If you'll identify yourself for the record, please.
Thank you, Madam Chairman. For the record, my name is Adam Plain. I'm the Insurance Regulation Liaison for the Division of Insurance. I had submitted a proposed amendment to the regulation earlier in the week, along with explanation. The only item I have concerning sections 2 and 3 is in section 3, standalone is defined as an insurance product that is offered by the exchange as a separate product from a qualified health plan. It uses the term product quite often, and if we remember back to, I think it's last week's plan certification meeting, there's a lot of confusion regarding the term product and plan and whatnot as it applies to insurance. So the division recommends striking the term insurance product and replacing it with a contract of insurance. In this specific case, as we're dealing with standalone, we recommend that standalone mean a contract of dental or vision insurance that is offered by the exchange separately from a qualified health plan. As in this context, dental and vision are the only standalone products available on the exchange.
So, Mr. Plain, are you suggesting that we put in dental and vision as well?
Yes, as
Okay.
a matter of avoiding confusion about other potential standalone products and their authority to be offered on the exchange.
All right, so you're suggesting we strike the words insurance product and insert
A contract of dental or vision insurance.
Contract of dental or vision insurance. Thank you.
And I do have copies of our proposed language available for distribution to members here in Northern Nevada.
Okay. Now, if you want to give a copy then to Athena for us to make sure that we accurately reflect that.
Certainly.
I appreciate your clarification on that. Mr. Hager?
So just to make sure that I got that down correctly, Section 3 would read, standalone means a contract of dental or vision insurance that is offered by the exchange as a separate product from a qualified health plan.
Yes.
All right. Are you comfortable with the word product in the latter part of the sentence?
Excuse me. Sorry. I missed that. As we have it proposed, it would be standalone means a contract of dental or vision insurance that is offered by the exchange separately from a qualified health plan. Part of the reasoning for this is insurance product is actually already defined in Nevada Administrative Code under Chapter 679B, and it specifically excludes healthcare insurance from the definition of an insurance product.
It's nice to have your comments. Thank you. Do any of the board members have questions of Mr. Plain? In here? Okay. Thank you very much. Do we have anyone on the telephone that would like to comment on either Section 2 or 3? All right, thank you. Mr. Haggard, then, do you want to move along to, you're combining Sections 4 and 5, or do you want to do Section 4 by itself, or do you want to combine the two of them together?
Madam Chair, I'd like to combine the two of them together because it explains why we've posted them as first parallel section and second parallel section.
Okay, thank you.
So Sections 4 and 5 are, for the most part, the same wording. You'll notice that we're adding Section 4 to the regulation, but then Section 5 says that Section 4 is amended to read as follows. And you'll see where the changes are to that to Section 4. If you read Section 5 on page 3, you'll see the strikeouts and the new wording for the various wording that changes Section 4 to the new section. And what this does for us is gives us a little more leeway the first year of the regulation to make sure we've got enough time to adopt fees. We'd still like to try and comply with this, but I don't know how much time. You never know what's going to happen, and we want to make sure we've got a little bit of leeway in here. And then it changes what we use as as the basis for average premium. So again, Sections 4 and 5 are labeled as the first and second parallel sections, and Section 5 is actually effective on October 1st of 2013. So we would have Section 4 as the applicable regulation beginning on the date of the adoption, so the January board meeting, and that would be effective through October 1st of 2013. And then effective October 1st of 2013, Section 5 would be effective with those changes that you see here. These sections lay out the process to create, adopt, and publish the fees to be charged to insurers for placing their products on the exchange. And by product, in this wording, I mean dental, vision, and qualified medical qualified health plans. For placing those products on the exchange website for enrollment by qualified individuals and employees of qualified small employers. These sections are labeled, again, as parallel sections because the first section is effective upon a filing with the Secretary of State and is then amended by the second section effective October 1st, 2013. This allows the exchange time to adopt fees following the adoption of the regulation in January, but requires the fees be adopted for subsequent years in a time frame that is more reasonable for carriers to certify their products. Section 4 requires that rates be set no later than February 1st, 2013 for the year beginning on January 2014, while Section 5 requires that rates be set no later than December 1st, 2013 for the year beginning January 1st, 2015, and uses the same timeline in future years. This section requires the exchange post the intent to adopt fees in the same manner as the board agendas are posted, no later than 15 days prior to the board meeting during which fees are adopted. And based on feedback that we've received, indicated that 13 months is probably more time than is necessary. So I would like to strike out on section 5 where it says no later than 13. I'd like to change that to no later than 11 months prior to the initial effective date. So they would have to be adopted no later than February 1st. Basically, the board would adopt the rates at the January board meeting. It will likely be the same as we are doing this first year, but just in case something goes awry this first year, will give us a little extra time. But in subsequent years, we should be able to have the information that we need to adopt appropriate rates for the plan year beginning January 2015 by February 1st of 2014. So if we could change 13 to 11, and that's the blue italicized information right below section 5 on page 3 of the regulation. Section 4 and 5, subsection 1 indicates the fee will be charged on a per member per month basis. It will be effective for 1 calendar year beginning on January 1st, and is a flat dollar amount rather than a % of premium. And I don't know if we discussed it at the board, but we discussed it quite in depth at the Finance and Sustainability Committee, that we would adopt a flat per member per month dollar amount fee as opposed to a % of premium because of the extra variables that are included in trying to estimate what premiums will be. The per member per month fee gives us a little better idea of what we can expect to get, assuming that our enrollment figures are right. But the only variable at that point is our enrollment, as opposed to also trying to include the variable of the premium amount if we try to adopt a % of premium. So that's why we adopted the flat dollar amount rather than the % of premium. However, the cost of dental and vision products are significantly less than health insurance premiums, and we've had quite a bit of feedback from stakeholders that offer vision and dental products, indicating that they agree that they should be charged something for being on the exchange, but that they should not be charged the same amount. The example is, if a medical premium is $300, a dental premium may only be $30. So it's quite a substantial difference. If we charge $10 to both, then the $300 premium goes to $310 and the $30 premium goes to $40. That's quite a large % increase. And so the request was made, and I think it makes sense to reduce the amount for dental and vision products, basically a proportional amount. So subsection 3 provides the calculation method, which requires that a prorated fee be charged to the 4 types of plans listed in subsection 2 based on the average premiums of those sections. So if you look at subsection 2, if you're on page 2, this is subsection 2 of section 4. The exchange will calculate separate fees pursuant to subsection 3 for the following types of plans. So paragraph A is a qualified health plan that does not include dental insurance. Paragraph B are qualified health plans that include dental coverage. Items C and D are dental and vision products. So subsection 3 creates the calculation method. So if we were to assume that the board approved the rates that have been included in the Finance and Sustainability Plan, and I think if you recall, it was I think the first year was $420 per member per month, and it went up to about $7.50, maybe a little bit more in the outer years. Let's take that fee, and just for easy math, let's pretend it was $10 per month. So let's pretend we were going to charge a qualified health plan that does not include dental coverage $10 per month. Paragraph A, the qualified health plans that do not include dental coverage would be charged $10 per member per month. A dental plan, let's pretend that a dental plan is 10% of the cost of the average dental plan is 10% of the cost of the average medical plan. So a dental plan should therefore be charged $1. So we take the average cost of a qualified health plan medical plan without dental coverage, and we compare it to the average cost of a dental plan. And we see that the dental plan is 10% the amount of the qualified health plan. So therefore, if we set a qualified health plan at $10, then the dental plan would be charged $1. And let's say the vision plan was even half of that, so 5% of the qualified health plan, then the vision plan would be charged 50 cents. So that covers items C and D. And then the last item, paragraph B, qualified health plans that include dental coverage would be charged $10 plus $1 for the dental, so they'd be charged $11. And so that is basically staff's proposal on how we calculate the fees for those 4 different types of health plans and insurance, what do we call it, contract for dental or vision insurance. Got to get used to the new terminology. So that's how we get through Section 3. Then finally, the question is, how do we come up with the average premium for those products? We obviously don't have an exchange product yet. So the recommendation is that we take the average premiums of plans offered, plans or products offered in the market if that data is available. And if we can't get that data, we can use comparable plans or products offered in the Public Employee Benefits Program, and we have confirmed that we can get that data if necessary. And so that pretty much walks you through the process for Section 4. As you've seen in Section 5, the time frame changes, and so staff's recommendation was to change, while it was 10 months in Section 4 and then 13 months in Section 5, we wanted to strike out 13 and change that to 11. And then the final change at the end on page 4, you'll see subsection 3. At that point, we will have products for sale in the exchange, so we will use an average of the products that are available in the exchange rather than in the market as a whole. A couple other items that I wanted to point out. You might recall that we defined what an exchange member means in Section 2, but we never actually used it anywhere in the document. We used the term member. So we'd like to add the term exchange in front of anywhere you see member, and there's 4 places, 2 in Section 4. So the second line of Section 4, you'll see for enrollment by members. You would change that to for enrollment by exchange members. This is on the second line on page 2. It says for enrollment by members. We would change that to say for enrollment by exchange members. And then under that you see subsection 1, paragraph A, be charged each month to insurers for each exchange member enrolled in the insurer's QHP. So we'd add exchange there. And then you would have the same changes to Section 5 because that wording would not have changed. So we'd add exchange in front of members in both of the same locations in Section 5. And I think that wraps up that section of the report on the proposed regulations.
All right. John, I have a question because you've got the parallel Section 4 and 5. Once we're past the initial year, one of these sections becomes moot, doesn't it?
Correct.
Do we want to put an expiration date in there so that we don't have to come back and take it out?
Because you are amending Section 4 on a specific date, Section 4 would go away and you would basically see Section 5. When they actually end up being codified in Chapter 695I, let's say it's 695I.300.
Okay.
Section 4 would be codified as Section 695I.300, effective probably January, let's say 11th, whatever that date is. And then Section 5 would be codified as 695I.300, effective October 1st of 2013. So it would simply, when they go through and clean up the regulations the following cycle, they would simply, that first 300 would go away and this would replace it, or whatever the section number ends up being.
Okay. Yeah, please, go ahead.
Okay, as I'm reading through this regulation, Section 4 is a little ambiguous when you get down to 1, 2, 3. the third line where it says subsection 1, the board will adopt and publish fees to be charged to insurers. And here's where it gets kind of funky for me. For the placement of qualified health plans and other products on the exchange's internet website for enrollment by members. If you read that literally, it kind of sounds like you're charging them to put things on the website, like post them, versus charging a per member per month fee. Maybe a slight change to the language would be for the placement of qualified health plans and other products. Strike out on the exchange's internet website and leave, strike that out and put in per member, exchange member per month for enrollment by members. That makes it a little more clear that you're not referring to charging the insurers for posting things on the website. The number 15 should probably be spelled out because that's just kind of standard practice. So the word 15 rather than the number 15. And the last sentence, such notice will be posted in the same manner and locations as agendas. I'd strike the word are. It kind of doesn't really fit grammatically. As agendas posted for board meetings, period. And those are my changes to that particular section. Thanks.
Do you want to go, let's go through them one more time because I know some of us are taking notes here. All right, so you're in section 4 or 5?
I am in section 5, previous section 4.
Okay.
Which reads no later than 13, which we've changed to 11. Okay, so if you go down to the fourth line, where it reads placement of qualified health plans and other products on the exchange's internet website for enrollment by members, that as you read that sentence, it sounds like you're charging the insurers to post things on the website. To be more clear, I would say for the placement of qualified health plans and other products, I would cross out on the exchange's internet website, 1, 2, 3, those 5 words, replace it with products per member per month for enrollment by members or something like that, so it's just clearer that you're charging them for the members' administrative fees versus for placing things on the website. That just kind of, as I'm reading it, that's what it reads like to me literally.
For the record, John Hager, so regulations are often very confusing. On subsection 1, we indicate that the fees charged pursuant to this section will be charged each month to insurers for each exchange member enrolled on the insurer's QHPs and products. Would that so we strike out on the exchange's internet website, so it would read the board will adopt and publish fees to be charged for insurers for the placement of qualified health plans and other products for enrollment by exchange members. And then the next section talks, or the subsection talks about the per member per month fees.
Perfect.
Okay.
And then the next thing, Barbara, was just the word, the number 15 should be spelled word 15.
I agree with you, and it's in both sections, both section 14 and 15.
Ms. Kerr, you indicated that...
Madam Chair. I'm sorry, this is Lynn. I thought you were done speaking, so I was going to chime in.
Okay. Can you give us just 1 second? I just want to make sure that I've got everything written down on this suggestion, and then we'll turn it back over to you. Do we have the same clarification in section 4? We do. So
if we can, we'll make all of the changes to section 4. Section 5 will be identical to section 4. Except for the changes that are the strike, the things that will have to change for the new time period. If I could ask Ms. Kerr, you said that another word had to be stricken? Stricken.
It's not really that material, but it just grammatically it sounds better. On the last line of previous current section 5, previous section 4, such notice will be posted in the same manner and location as agendas, just strike the word are, as agendas posted for board meetings. You don't need the word are there, and that's just, not really material, but grammar.
Okay. Does that reflect all of your suggestions then?
Yes, thank you.
Okay. Then, Ms. Atkins.
Yes, just in listening to that, I think, did we keep the part that says fees to be charged to insurers for the placement, because I think for the placement's referring to the website.
Let me read it to you the way that I believe, and correct me, Ms. Kerr, if it's incorrect. And I'm reading from Section 4. It would be no later than 10 months prior to the initial effective date provided in paragraph B of subsection 1. The board will adopt and publish fees to be charged to insurers for placement of qualified health plans and other products for enrollment by exchange members. And then it would spell out 15 days prior to the adoption of such fees, the exchange will post a notice indicating the board will adopt fees. Such notice will be posted in the same manner and location as agendas posted for board meetings.
Yes, I think for placement referred to the website, and so it needs to either be changed or stricken.
Okay. Do you have a suggestion on that language? First insurance.
No.
If we just strike out for the placement of, does that take care of it?
Yes, I believe so, Madam Chair.
Yes, I agree.
Okay.
And I have a question when you're ready, Madam Chair.
Yep, just one point of clarification. So the part to be stricken would be for the placement of the 4 words?
Yes, so the board will adopt and publish fees to be charged to insurers for qualified health plans and other products
Okay, so we're
for
leaving the word.
enrollment by exchange members.
So we are keeping the word for in. Okay, thank you. All right, Ms. Johnstone, thank you.
Thank you. It's Leslie Johnstone. This is such an obvious question. I think I missed something. In subsection 2 of section 4, where we list the A, B, C, and D plan or products, we don't anticipate a qualified health plan that would include both dental and vision?
For the record, John Hager. So, and it's actually not an obvious answer, and it is a good question. The Affordable Care Act sets up qualified health plans that include the 10 categories of essential health benefits. One of those categories is pediatric dental and vision coverage. There is then an exception for dental coverage, and it says something along the lines of, if the exchange has a product, a standalone dental product that is other than it doesn't offer anything but dental, it's a qualified health plan, it's a qualified dental plan on the exchange, then the other qualified health plans do not have to offer a dental plan. So as long as we have a dental plan standalone, then we can offer qualified health plans that don't include dental coverage. However, there is no such exception for vision. But that only applies for pediatrics. For adults, there is no requirement, there is no essential health benefit for adult vision and dental coverage. And so we could have a standalone dental plan. The board has approved also offering a standalone vision plan that's separate, but boy, I think I'm just confusing this even more. I apologize, but they can offer a standalone vision plan for adults, but you cannot offer standalone vision for children because they are, under our current reading, they are, each of the other qualified health plans is required to cover vision coverage. So we definitely see that we would expect to offer standalone dental products. We are pretty certain we can offer standalone vision products. I guess your original question is, would there ever be a case where we would offer dental and vision in one product? And we honestly had not considered that, but maybe.
And it was really if we would expect a qualified health plan that would include dental and vision.
We do expect that a qualified health plan will include, it will always include pediatric vision. There may be some that include pediatric dental and some that don't. We're not sure about that. As far as adults go, my guess is that it probably won't include dental and vision. Not that we don't want them to include dental and vision, but that it would be an added cost and therefore an added premium. And because of the price sensitivity of the market, it will likely not be included in the qualified health plans. We are, as an aside, we are trying to design the exchange web portal, the demonstration of the prices, so that if you choose a qualified health plan that doesn't include the pediatric dental benefit, you are going to have to be forced to choose a dental plan, a standalone dental plan for your children. But we want to make sure that you have an apples-to-apples comparison of the premiums. So we're working on a way to show those premiums appropriately so that we don't automatically have people choosing the plans that don't include dental coverage. Becomes very complicated, but as far as the idea of offering a dental and vision product together by itself, I didn't consider that. We didn't consider that. We do expect, again, that they would be offered in the qualified health plans, but because all medical QHPs are required to provide vision coverage for children, we didn't break that out separately. And again, I don't think we'll end up with that that type of product for health plans for adults, but I could be wrong. Did I just completely confuse the whole question?
This is Leslie Johnstone. I might have followed some of that. I don't know if it would hurt, just in case, to incorporate that option in the fee calculation so that if we do get a plan with those products in it, that we haven't prevented anything from being administered via the regulations. So I don't know if that's absolutely necessary. I just put that out there for the board's consideration.
We're thinking here for a minute.
So I think for children, paragraphs A and B of subsection 2, qualified health plans that include dental and don't include dental, those two items will include vision coverage for children. And so for a child, they would have those two options for QHPs, and if they didn't choose the plan with the dental coverage, the next step would be to choose a standalone dental product for that child, and they would never have the option of choosing a vision product on top of the vision that they already have with a qualified health plan. For adults, it is likely that the two qualified health plans in paragraph A and B would not include vision because of the price sensitivity, and therefore they would go through the options of selecting a dental plan if they didn't already with the QHP, and then the vision plan as well if they want it. So I guess the question is, if a qualified health plan includes vision coverage for adults, should we include that? Should we include an option for a qualified health plan that includes vision for adults? Did I summarize that correctly?
This is Lynn. Is it possible to have two lists, one list for children and one list for adults, to separate them out?
Say anything is possible.
I don't know if that will make it more complicated or not. It seems like those are the differences, the nuances that you keep talking about, and I'm just wondering if it would be clearer to say for plans for adults, ABCD, for plans for children, ABCD.
So,
Yeah, and
Mr.
this is
Weldon?
Leslie Johnstone. You know, maybe it's not something that we can answer today. I would just ask for it to be reconsidered. And then if it's not appropriate, a change, that's fine. But if it is something that's possible, I'd rather just account for it ahead of time so we don't have to revisit this.
Mr. Weldon?
Mike Wilden, for the record, and I think I am getting more confused. So this is for John, maybe just. So I thought to be a qualified health plan, and you had to have children's dental and vision. And so the only option is whether you add adult dental and vision, right? And so a qualified health plan by definition has pediatric dental and vision. And so I'm wondering if we have to now just say, go back to the NRS, it defines a qualified health plan and it says, whatever the feds say, it's a qualified health plan, and the feds say pediatric dental and vision must be provided.
So the statute NRS 695I defines qualified health plan as whatever it says in the Affordable Care Act. There is a list of 10 categories of essential health benefits, and the 10th category is pediatric services, including dental and vision. However, right after that, and I'm not sure exactly how right after that, it may be a couple paragraphs down, it says, except for dental products. It says that if an exchange offers a standalone dental product, offers just a, like Delta Dental or whatever organization comes in and says, I want to offer a dental plan for kids and for adults, for whoever, at that point, then the other qualified health plans do not have to have dental coverage for kids because there is another option to get that through a standalone dental product. There is no such exception for vision products, so all qualified health plans have to include pediatric vision. Now, there are some interpretations out there, I believe from Maryland, that interprets it differently for the vision side of it, and we're trying to get through that. But the initial reading of it is that qualified health plans for kids has to include all 10 categories except for the half of the category that says dental. They have to include vision but not dental, as long as we have a way for that child to purchase dental coverage by itself. So that's why there's a difference between paragraphs A and B.
John, point of clarification, when you're talking about paragraphs A and B, is it that include dental insurance or coverage for everyone, or is it just pediatric, and do we need to insert pediatric in front of that?
I don't know.
Madam Chair, this is Leslie Johnstone. I think this is complicated enough. We just need to let staff review it some more and then incorporate our comments in the next version.
Thank you. Do we have any other comments from other board members on section 4 and 5? Mr. Mullenkamp.
I'm sure just a question, actually, and maybe this, I missed the last meeting, I apologize. Maybe this has been addressed elsewhere, but do we ever discuss reserve balances that might be created? Is that contemplated in the regulations here or elsewhere?
For the record, John Hager, so the reserve balances are not contemplated here. However, in our finance and sustainability plan, we discussed setting a fee in the initial year to create a reserve that's equal to a 60-day reserve. So a 60-day operating reserve at the end of fiscal year 14, I believe. That reserve goes up almost to 100 days at the end of fiscal year 15 and then immediately drops down to about 40 days at the end of fiscal year 16. The goal is to have a long-term reserve of 30 days. So we'd have a 30-day reserve, I think, fiscal year 17 and beyond. The reason why why we're targeting a reserve of 60 days initially is because we don't exactly know what our enrollment's going to be. We've got some estimates based on expected uninsured rates and expected uptake rates. It's very difficult to tell what exactly enrollment will be. So we are again shooting for a 60-day reserve, and if our estimates come under what we expect, hopefully that 60-day will be able to account for that. We don't think we need to maintain a 60-day reserve in the long run. So what we do is we set a rate to cover our costs. And in the first year, the only costs we have to cover are navigators. The rest of our expenses are paid for by the Affordable Care Act establishment grant funds. So the first year fee is substantially lower. I think it was about $420, and we'll revisit the actual rate at the next at the rate setting meeting. And we gradually build that rate up to our long-term rate while we increase our reserves initially and then bleed those off through a lower rate than what is required till we get to a long-term rate with a stable reserve.
Thank you. I think if I could follow up, I think my main question is in regulation somewhere, either here or elsewhere, is it contemplated that if reserve levels come below a certain amount, 30 days or whatever that established amount is, or they exceed a certain amount, say 120 days, that there would be it would prompt board action to be able to address that particular concern or issue? I'm assuming that it takes board action to raise rates, but maybe I'm wrong about that. Or for that matter, to lower rates.
For the record, John Hager, so this regulation contemplates the board reviewing rates on an annual basis. So regardless of what happens, the board will review the rate every year to make sure it's sufficient to cover costs and to make sure we have a sufficient reserve. It's difficult to change rates in the middle of a year because the carriers are assuming that you will have a rate set, and that is an expense of their plan. And so they need to be able to plan prior to the certification process and rate review process. They need to have what that rate is, build it into their rates, and then they charge it. So the reason why we have this upfront 11 months and 10 months in Section 4, we set the rate 10 or 11 months in advance. They do it. They provide it as an expense in their premium. In the rate review process, it goes to rate review, certification, the onboarding process, which includes taking that approved plan and putting it in the exchange. Then you have open enrollment, which starts October 1st in the first year. It starts October 15th in subsequent years. And the effective date of that rate is not until January 1st. They need to have a set rate for a year or whatever amount of time it is. They need to be able to count on that rate so that they can accurately predict their premiums.
Just a final comment, then. I think that helps me knowing that you really wouldn't be in a position making mid-year corrections. It would be my suggestion that initially, due to the uncertainty of this, that you probably keep your reserve levels a little higher than lower, because if there's not an ability to make a mid-year correction, you'd hate to run short.
So a couple things that can help that. Currently, the last section of our statute allows us to take an advance from the general fund, assuming, Director Mullenkamp, that you approve it. And that has to be paid back by the end of the fiscal year. The rates that we're setting are for calendar year. And so if we get to a point where our fiscal year reserve starts getting low, we can take an advance and hopefully get past that hump and increase rates for the next calendar year. So it's doable. It would certainly, we'd have to make sure it works, but I think that we're okay with a 60-day reserve. If the board feels more comfortable charging a fee that creates a slightly larger reserve for the first year, we could do that. We would certainly want to decrease that to a long-term rate. So basically, we would end up giving that back over time till we got to a reserve that was a more reasonable over the long term. But certainly, because of the volatility in the first year, we could reconsider the reserve for the first couple of years.
Yeah, I think that addresses my concern. I think the general fund advance, the ability to correct it mid-fiscal year, I think satisfies my concern.
Thank you. Do we have any other questions from Las Vegas?
No, Madam Chair.
Okay. Dr. Klein, do you have any questions or comments on the regulation?
No, thank you. I've been listening, and I'm impressed with the level of detail of work that Mr. Hager has done.
Thank you. I have a question for Mr. Plain, if you want to come forward, because we're using the same terminology again, and I'll focus just on Section 4. Do you anticipate any problems with our using the word products throughout Section 4? If we needed to change it, I would suggest we look at it now and then do corresponding changes in Section 5.
And Mr. Plain, if you don't mind, can you remind me what that NRS was that defined product?
Certainly, for the record, Adam Plain, Nevada Division of Insurance. Mr. Hager, to address your question first, it was NAC 679B.822, subsection 3, paragraph B. 679B.822, 3B, and that's in the administrative code and not the revised statutes.
Thank you.
And then Chairwoman Smith Campbell, I would agree that given the change from the term products to contracts of insurance, that phraseology should be carried out throughout the rest of the regulation.
Then if, John, you might walk through this with me and Mr. Plain as well. So looking at Section 4, page 2, the first line, we've got other products. We've had some amendments to that sentence in that paragraph as well, but that would read qualified health plans and other contracts of insurance. Would that be the correct terminology?
That is correct.
Okay, and then I don't see the word products again until we get down to subsection or paragraph 1, subsection A. The last of that line, we've got products. And then again in subsection C. Then we go to paragraph 2. We've got products at the last of that first section there, and again in subsections C and D. In the first line of paragraph 3. In the second line of paragraph 3. Top of page 3 of subsection 3, where the line reads charge for the type of product. We have product there. Next line down at the end of that line, product again. And then in subparagraph A, the average premium of plans or products, how would we restate that? And it's in both A and B. Contracts of insurance rather than plans or products?
Madam Chair, if I might, we can go back and make sure that product is either we use a different term that is more appropriate, or that we clearly spell out product and replace it with contract of insurance, and we'll make sure that we do that for every place that product is mentioned here.
Okay. But I just want to make sure that we're consistent between the different sections when we start using those terms. So, but at any rate, I think we've identified it in Section 4, and we'll go ahead and duplicate those changes in Section 5. So I'll open it up to public comment from anyone in Las Vegas.
We have one person coming forward.
Thank you.
Good afternoon. Leanne Gasaway with America's Health Insurance Plans. Thanks for having me today. One kind of conceptual comment, and then one comment on something we might want added to the regulation, or at least addressed in some fashion. I know that John is aware of this issue. One is the transparency of the fees. So I realize that we're going to publish the fees on the website so that savvy health consumers might be able to find it on the website. But also, as the shopping experience is going forward, I think it's also important that we be transparent, that this fee isn't hidden from the user, that this is part of the exchange's value, and that this is a fee that's being added onto their premium for purposes of purchasing through the exchange. So I think transparency is a very important concept. I'm not sure how that could be incorporated here, maybe somewhere in section 4 and 5 where it talks about how the fee is going to be displayed or how it's going to be expressed to consumers. The second one might appropriately be under subsection 1, where the fees charged would not be considered premium for purposes of the premium tax. So, for example, if this fee is incorporated as premium, the health insurers would not only be paying the user fee to the exchange, but they'd also be paying a premium tax on top of that user fee. So they're paying twice, if you will, on the business being placed in the exchange, and I think that that's something that we'd like to avoid from an affordability perspective. So I think it could be addressed. I know there are potentially legislative issues around how this fee is going to be incorporated within the premium, but maybe under 1, create a new subsection D, where it said the fees charged pursuant to this section will not be considered premium for purposes of the premium tax. And that way it would be clearly a user fee or an assessment and not premium. And that also would help in determining that the premiums being charged inside and outside the exchange are the same, because that premium, that base premium for that product, both inside and out, would be the same. Thank you.
We've discussed that. Thank you very much for putting it in public comment. But maybe Mr. Belcourt, who's our Deputy Attorney General, might help address that question.
Yeah, I believe this would not be the probably the effective way to approach that, because I think the premium tax would have to be clarified. And I believe there's a bill draft that is going through the process to do that, because you can't change the premium tax in regs concerning health insurance exchange.
For the record, John Hager, yeah, for the tax, we submitted the BDR, this board submitted the BDR to exempt the exchange fees from the premium tax calculation. And it's in statute, so again, to reiterate what Mr. Belcourt said, I don't think we can change statute by regulation, and I would be very uncomfortable affecting state general fund revenues through a regulation, through a board that is not subject to the Administrative Procedures Act without going through the proper legislative procedures. Again, the board did submit that BDR, and we're working with the governor's office on that BDR. On the issue about transparency and listing the fee on the website, it's my understanding, and I have to review this, but I think that the Affordable Care Act and its regulations require that we list the fee on the website, that we be transparent. So I'm not sure that an additional regulation at the state level would be required. Again, we intend to make sure that the fee is available on the website. We have every intent of being transparent. Madam Chair?
Thank you. Is there any other public comment in Las Vegas?
Good afternoon. For the record, Jack Kim from United Healthcare. I wanted to address a question that Ms. Johnstone brought up, and then Mr. Wilden asked questions on. This is really about the plan designs and whether a plan in a qualified health plan would include it. Would we in the industry would call it an embedded vision and dental product? The way the regulation is currently drafted, it looks like we would be allowed to embed a pediatric vision which is required by the ACA. We could include a pediatric dental, but the way it's drafted, we couldn't include a full dental or vision product. And I think that's what Ms. Johnson was going at. I think by not allowing for that, you will have situations where individuals will come into the exchange, look at the products, and maybe go off the exchange because they want to get a product that contains everything. I think you want to give the flexibility for a plan to have both an embedded full vision and an embedded full dental product. Thank you.
Thank you for your comments. Anyone else in Las Vegas? All right. How about here?
No, Madam Chair.
Thank you, Ms. Johnstone. Anyone here in Carson City? Mr. Plain.
Thank you, Madam Chair. Again, for the record, Adam Plain, Nevada Division of Insurance. I have some suggested amendments for sections 4 and 5. I don't think it prudent to go through them line by line because we still have item 5 and so on at the board meeting to continue through. The gist of the suggestions are, again, bringing the term product in line with contracts of insurance. As Mr. Hager already addressed, changing the usage of the word member to exchange member. There are some minor punctuation items, but the majority of it centers around an alternative for you to consider, an alternative methodology that would eliminate the need for Section 5. It doesn't change the policy of the regulation at all. It just reformats the phrasing so that having Section 5 amend Section 4 isn't necessary. It's all taken place in one section. Possibly offers a cleaner alternative for you to consider. Beyond that, a couple of the items that have been discussed, I believe the Division of Insurance would support the change of the 13-month time frame to the 11-month time frame. 13 months seemed rather long, and that the 2015 fees would actually be adopted before the exchange went live on 1/1/14, and that seemed a little excessive. In the first sentence of Section 4, when it talks about the 10-month countdown for the initial fees to be adopted, just as a point of reference, I calculated that to be March 1st, 2013 and not February 1st, 2013. So that gives you one extra month if you use that time frame. And then the final item is an item that I believe the division will want to discuss with exchange staff to coordinate some regulations on, and that is the usage of the term calendar year versus policy year. The Affordable Care Act loves to use the term policy year, and that has a dramatic effect on how a calendar year fee would be applied. And so I think that's something that we need to put our heads together on and come up with some ideas and solutions so that way the exchange and the off-exchange market run as efficiently as possible.
If I might, Madam Chair, I agree with just about everything that was said. The two items that I don't know, not necessarily differ, but to clarification. So part of the reason why we had parallel sections 4 and 5 was so that you visit this regulation once, Section 4 goes away, and there's no longer any old wording. You don't have to go back and amend it. Either way works, and so, but that was the thinking behind doing the parallel section, so that it automatically goes away. We don't have to later on go back and remove a section that is old and doesn't apply. The second part was the discussion about policy versus calendar year. I absolutely agree with Mr. Plain that policy year is used quite substantially throughout the Affordable Care Act. The issue was how we treat shop and individual separately. The small group market, a plan year could start on the 1st of any month as opposed to the 1st of January, and it becomes difficult it will become difficult for us to track that as well, and we could do it various ways. The idea was, though, that we set a rate and it's effective from January 1st through December 31st of a year, so that if you had a small employer plan that started, say, July 1st, that rate would be effective July through December, and there would be a new rate for January through June. Now I can see a potential issue where we're not set so that January through June rate is, that second half of the year is set in January a year prior, but the policy was issued in July, and so that plan would have already been rated earlier. So that could be a concern. The carriers would have to figure out that rate and add it in, and so that could be an issue for the carrier. It depends on how the board wants to go about, if they want to set a rate for a year so that we have a better idea of what our rates, our fees are for the year, or do we set it for policy years beginning on or in a calendar year? And I don't know what the best answer is for that.
I think either way you do it, somebody's going to have to make adjustments. So, anyway, if you have your comments written, I know the two of you will be working together with staff to come back with looks like we're going to have another workshop on this because of all the changes on it. But we'll look forward to that. Any other comments that you had?
No, Madam Chairwoman, that was all.
Okay. Do we have any other public comment here in Carson City? Mr. Wilden?
I'm sure you're getting ready to leave item 4, or I just had a question for Mr. Hager.
Okay, no, I'm going to see if we have public comment on the telephone, and then I'll open it back up to the board. Any public comment from telephone participants? Hearing none, Mr. Wilden?
John, if you could, on page 6 of the handout, not the 4A, the 4 itself, I just was curious if you could provide a little more comment. Under the figure 5, you make a statement, it should be noted that the cost of the federally facilitated exchange may be extremely high, perhaps double the Silver State exchange, and cautioning and that. So could you provide some additional comment there? I'm just curious as high and perhaps double. I didn't know where we arrived at those numbers.
That is the rumor from reliable sources.
Rumor from reliable sources. Okay. I just wanted to make sure.
All right.
Madam Chair?
Yes.
Lynn Atkins for the record. So John, it looks like staff or you submitted all of this to LCB last week. Do we think we're going to hear back from them, or do we think we're not going to hear back from them on their analysis of the regulations?
I don't think we'll hear back from them because we're exempt and they are slammed with bills. I would not expect to. But that doesn't mean we won't. I don't think we will, though. Now I'm sorry. We have gone over this with the Attorney General's office, and we'll continue to go over this with the Attorney General's office and the Division of Insurance for the next workshop.
But Ms. Atkins, the one thing that we are doing is communicating all the time with LCB and the legal staff, so that if they do have time to review it, they've got, they have notice of it at the same time that we're reviewing it. So if they see something that really is awry to the statutory intent, I think that they would be getting back to us.
No, and it sounds like with the AG's office and the Division of Insurance, I just wanted to, I think staff is obviously working very hard on all of this, and it's very complicated to do, and I just was hoping that there was a couple sets of eyes on folks who had experience drafting regulations and the legal ramifications of all these that, I don't have that experience. So that was just the basis of the question.
Thank you. Any other questions or comments? Do you want to go over that? Yeah.
So before we leave agenda item number 4, the impact on small business statements on page 5 and 6, and as Mr. Wilden pointed out, these are costs. However, again, we understand that the federally facilitated exchange costs might be as much as double as the exchange fees, even more in the first year since our fees are so low in the first year. So these really could be savings if you consider that if we didn't do this, a federally facilitated exchange would come in and they would charge higher rates. These fees that are listed here, you see them. These are the estimated fees that we provided in our Finance and Sustainability Plan. They assume that the lower exchange eligibility threshold is 100% of the federal poverty level. These fees change slightly if the state determines that it will expand Medicaid. However, for the first year, we have the plan that we put forward and approved was that the fee would be $420 regardless of whether we expand Medicaid, and that we would simply reduce the reserves. And I think that the reduction in reserves went from 60 days to 51 days. But assuming that the rates that we provide here are approved, then this is what you would see. So based on that, when we estimate the annual cost to an employer who covers 25 employees with 2 dependents each, so 75 total covered lives, and the employer pays for 100% of the cost of coverage, you can see that the fees that would be charged by the exchange to the carrier and then passed through to the employer could be as much as $3,700 and $5,400. Now, we're not sure exactly if this will be, it will actually be built in as a 1-for-1 ratio because it's an expense to the carrier while it's passed on to employers. It's passed on, the rates for qualified health plans are the same both inside the exchange and outside the exchange, but in general this is about what you can expect an employer to pay. Now, again, this does not include the premium, the health premium, so the amount of the health premium would be a lot higher for those 75 lives. This is simply the portion of the premium that would be paid to the exchange for those 75 lives. When we look at figure 3, for 25 employees and the employer pays 50% of the cost of coverage, the cost to the employer is about $600 and $900 in 2014 and 2015. For an employer who covers 50 employees and pays for 50% of the cost of coverage, you can see the numbers in figure 4, $1,200, $1,800, $2,100, and $2,200. And then for 100 employees with 50% of the cost of coverage, there's no cost provided in 2014 and 2015 because you can't be on the exchange if you have more than 50 employees in 2014 and 2015. But 2016 and beyond, the exchange enrollment will be opened up to employers with 100 or fewer employees. So that employer that has 100 employees and pays for 50% of the cost of coverage would pay approximately $4,300 and $4,500 in 2016 and 2017. So when we went through this, we had to try to determine what is an impact on small business. And of course, we are charging the carrier, not the small employer. So I kind of skipped through this analysis, but most carriers have more than 150 employees, most if not all. Now, there are some groups, some subsidiary groups of employers that might be fewer, but the relationships are so jumbled up it's difficult to say what a small employer is or isn't in the insurance industry. So we didn't really say there was an impact on the carrier. These fees are charged as far as a small business goes. These fees are in fact charged to the carrier, but they increase their rates and subsequently pass that on to the small employer, which is why we said that this is a cost to a small employer and how we broke this out by 50 or 100 employees. So that's how we came about this. For the analysis on the impact to small business, if we go by the definition in NRS 233B for small business, it's 150 employees. So different from what we consider for the shop exchange. But in any event, it covers the small employers on our exchange, and this is how we came up with those figures on the cost. Should also be noted that the fees charged by the exchange are in line with those charged by private exchanges, and the service provided by the exchange are similar as well. Furthermore, it is optional to be on the exchange. So an employer with 50 or 100 employees is not required to be on the exchange. However, figure 2 and 3 discussed the impact to exchange or to employers with 25 or fewer employees. We thought it was important that we do 25 or fewer employees because the only way that you can get the tax credit from the federal government is which is provided to employers with 25 or fewer employees. The only way you can get that is by being on the SHOP exchange. That tax credit, I believe, expires at the end of 2015, which is why we only showed it for 2014 and 2015. So the fact that a small employer gets a tax credit, we basically considered the enrollment in the exchange as quasi-mandatory. You don't have to be on it because you don't have to get the tax credit, but if you want the tax credit, you have to come on the SHOP exchange. So really in all these figures, figure 3 is probably the most appropriate one because to get that tax credit as a small employer, you have to be on the exchange. It's very typical that small employers provide a 50% contribution for the cost of coverage, and so 50% of our premium would be provided in figure 3. So figure 3 is more than likely the closest estimate to a real impact to employers for a, again, quasi-mandatory program.
All right. Thank you, Mr. Hager. If there are no other comments on agenda item number 4, which is our workshop, I'm going to close that agenda item. And I think what I'd like to do is take a 5-minute break and then come back on the record. How does that sound? All right, are we about ready to go back on the record? All right, just as a reminder to everyone here today, too, the video conference must end at 4:30, and at about 4 o'clock, someone will come on the line and remind us that we've got 30 minutes before they'll shut the system down. So just as a nice courtesy to everyone, we will have to wrap this up a few minutes before 4:30, if not before. So with that, let's go back on the record. We're at agenda item number 5. And Mr. Hager, this is our annual review for election of chair and vice chair.
NRS 695I.320 requires an annual election of the chair and vice chair. Barbara Smith Campbell and Leslie Johnstone were elected to the positions of chair and vice chair by unanimous vote of the board on October 26, 2011. Chair Campbell's and Vice Chair Johnstone's terms as members of the board expire June 30th of 2014. And the bios were all posted online. I would like to note, not that any of our ex officio members want to be chair or vice chair, but they could be chair or vice chair. And or any other member of the board could be chair or vice chair. We posted the expiration of Chair Campbell's and Vice Chair Johnstone's terms as board members, just to make sure everybody was aware of when their terms expire. This next term as chair and vice chair would expire November 8th of 2013. So if they were reelected, they would be able to be chair or vice chair throughout the remainder of that annual term. So with that, we'll take any recommendations or nominations for election or reelection from the board.
I'm going to open it up for discussion among members. Ms. Johnstone?
Madam Chair, yes, this is Leslie Johnstone. While it's been a tremendous pleasure to be the vice chair for the first year of the exchange, I would like to offer it up to other board members. And at this point, I would be prepared to nominate Lynn Atkins to be the next vice chair. Atkins, sorry.
Thank you.
This is Ron Klein. I would second that nomination.
All right, so we have a motion and second to elect Lynn Atkins as vice chair of the Silver State Exchange. All in favor of that motion?
Aye.
Aye.
All right, thank you. Congratulations, Ms. Atkins. Yes, next is chair.
I'd like to nominate the current chair to continue as chair.
Madam Chair Lavon Lewis, I'd like to second that nomination.
As point of discussion, thank you very much. It's been a pleasure. All right, all in favor of the motion?
Aye.
Thank you very much. I believe that we have concluded our duties for election and re-election of chair and vice chair. And Ms. Atkins, I look forward to working with you next year. Thank you. And Ms. Johnstone, thank you very much for your service this year.
Thank you. You're welcome. And thank you. I look forward to working with you too.
Next item on the agenda is the Executive Director's Report. So I'll turn it back over to Mr. Hager.
For the record, John Hager. So a couple of things, actually, before we get into the rest of the report, major events. I don't think we've updated the board on essential health benefits. This board on, I believe it was September 18th, recommended that the Division of Insurance recommend to the Secretary of Health and Human Services that the state of Nevada adopt one of 3 of the potential benchmark plans. And I believe they were plans A, D, and F. Plan A was the HPN point of service plan. Plan D was the PEB, PPO, high deductible health plan, and Plan F was the hometown health HMO plan for PEB employees and retirees. The Division of Insurance reviewed those that information and through their processes determined that there were several outstanding questions. I believe we had identified some of those outstanding questions, and they felt that it wasn't appropriate to make a decision, a final decision on essential health benefits. A couple of outstanding questions include what exactly is pediatrics. We don't know what the age cutoff is for pediatric services. We don't know what discriminatory benefit design means, and several other questions. So based on that, the state of Nevada was unable to provide a final recommendation to HHS. The next steps for essential health benefits, HHS is currently reviewing all of the submissions of the various states or non-submissions. In the case of Nevada and any state that has not made a final selection, the default was the largest small employer plan. So by default, currently Nevada's EHB is the HPN Point of Service Plan A that was listed in all of the board materials. The information from Nevada and from the 49 other states and the District of Columbia will be compiled and will be issued in a regulation for public comment. We don't know exactly when that regulation will be issued. The latest term of phrase is soon. We expect to see the regulations sometime between next week and the first week of December. That's kind of the latest that we've heard, but again, soon is more often used than actual time frames. Once that list of essential health benefits and potentially the actual final regulations, actually, I come to think of it, I don't think they've even had any regulations. It's just been a bulletin. Once those regulations are issued, there will be a 30 to 60-day public comment period. At that point, all of the public can enter their comments for consideration by HHS, and the state of Nevada will also have the opportunity to provide additional input and determine again or recommend again to HHS what we expect the essential health benefits package to be. So just an update for the board. I'm sure DOI is anxiously awaiting that, and they're keeping their eye on the Federal Register to determine what the next steps are. Again, we don't know what those next steps are until we see those regulations. And in this case, when I say we, I mean the Division of Insurance. So they're working on it. Once that public period is over, then it will go to back to HHS for consideration of all comments, and there will be a final regulation that will be published probably in January or February timeframe, hopefully in enough time for the plans to do their plan creation, certification, etc. The other item that's not on here is the declaration. The declaration is due from the governor on next Friday, the 16th of November. We have been in communication with the governor's office, with the staff, and we are working with the governor's office to draft a declaration that gets done what needs to get done. Again, we won't know what the final verbiage or letter will look like until November 16th. With the declaration, we will be submitting the blueprint, and actually the blueprint is actually being submitted earlier. We've already submitted 8 of the 12 sections. We believe that close out those sections and should provide the CMS and CSIO, Centers for Medicare and Medicaid Services, and the Center for Consumer Information Insurance Oversight with the information they need to certify us or conditionally certify us by January 1st according to this Affordable Care Act. The remaining 4 sections, we are putting the final touches on that, and those should be submitted sometime next week. To use the federal term soon, but it will be by Friday, hopefully earlier. Although we have heard rumors that the requirement for submission of the blueprint might be pushed back, we want to maintain our current schedule and get it done by next Friday so we don't have to deal with it anymore, because it does take a significant amount of staff time to provide that information. If you would like to look over the sections of the blueprint that have been submitted, you can find those under, I believe it's reports. If you go on our website, the section is reports and then gate review. I know it's not real clear, and we're working on that part of it. And under gate review, you see design review evidence matrix 1 through 12, but it skips 4 of the sections that aren't there. Those are the 4 that we're working on submitting. So when we When we submit them, we also post them on our website. We're trying to be as transparent as possible. If you have any questions about any of that, obviously you can go to the website at any time, or you can contact us, and we'll help you through it. So far, the advisory committees have made 28 substantial recommendations to the board, of which the board has approved, and I believe it's really 23 because of the clarification about the navigation or the navigator and producer document. But in any event, quite a lot of work has been done by this board. That information can be found also online on the About page if you go to recommendations approved by the board, and it's all correct except for the recommendation to approve the navigator and producer item. We will update that when we get a chance to, but that obviously needs to be fixed. And so you see certification, January 1st, 2013. That's certification by the Secretary of Health and Human Services. That is certification of the exchange. That is different from certification of a qualified health plan, which will occur sometime in the late winter, early spring. We have the legislative session listed there. 327 days to go live. We're counting down the days and trying to stay on top of the plan. Technical implementation is going well with Xerox. Staff meets with Xerox probably 3 to 4 times a week. We had an 8-hour meeting. I think it was 8 hours on Tuesday. We had a 4-hour meeting this morning to go over the requirements and configurations of the Xerox Choice Administrator web portal. In mid-November, we should be able to close out our design review. And actually, I should correct that. Probably mid-December, we'll be able to close out our design review. We are finishing up the IT requirements of the design review. We have determined with the feds that we will not actually have to travel out to Washington, D.C. for that. We told them that basically if we did that, we would lose a whole week here, a whole week of implementation. And so we are going to continue to correspond via email, phone conference, and perhaps video conference, but that design review should be done in about a month. And then the last gate review is the implementation review, which should take place in the spring. On to the advisory committees. You might have noticed that we have the pace of the advisory committees has decreased substantially. It's not quite as crazy as it was in the spring. We only had a few meetings. Finance and sustainability is done. Plan certification, we met and we have several recommendations regarding certification, network adequacy, and accreditation. And we've got a few more things to consider: qualified health plan service areas and continuity of care associated with churn. The Consumer Assistance Committee is going over appeals, and the next meeting for the Consumer Assistance Committee is November 15th. We added that meeting from previously we only had November 29th down. We added November 15th to try and get that done, so that we got a little extra time between the 15th and the next board meeting, which is on December 13th potentially, and also if we wanted to provide any extra documentation in that the last minute for our blueprint. I'm not sure if we will or not. So we're not sure if we're going to need the November 29th Consumer Assistance meeting. The agenda for the November 15th meeting will be posted probably this evening, but maybe as late as tomorrow morning. It has to be posted by 9 a.m. tomorrow, so we'll get that done. And then the Plan Certification and Management Committee will meet on December 7th. SHOP is complete with their recommendations, and for reinsurance and risk adjustment, we are simply waiting at this point for some information on the models, the federal models for reinsurance and risk adjustment, so that we can do an adequate comparison from what we might do compared to what the feds are doing. The regulations and the guidance for the regulations are out, so the remaining piece is the model, which we expected in mid-October, but again, that kind of stuff has been pushed, and we're hoping to get that between the next week and the first week of December. And so once we get that, we'll be able to have a better idea about the reinsurance and risk adjustment. The reinsurance and risk adjustment is required to be declared on the declaration, and what we have recommended that we simply state on the declaration that we have been unable to provide a recommendation or a direction on reinsurance and risk adjustment, And I believe the commissioner is looking at that language to see if he approves of it as well, that the state of Nevada can't make a selection on whether or not they want to do a federal administration or state administration of the reinsurance and risk adjustment programs until we have a little bit more information. We have been told that that it's not vital that we get that on there, that the decision to do that really needs to be made by March. So we still have some time. And they understand that we're moving ahead and looking at all the options. So that won't hold anything back. Contracts, the status of contracts, a summary table is on page 4. It's table 3. You can see the Xerox contract is moving forward. The independent verification and validation contract with Public Consulting Group is moving forward. We have 3 consulting and actuarial contracts, which we are taking to the Board of Examiners next Tuesday. So we hope that will be, those 3 will be approved next Tuesday. Those were the ones that were ratified by the board at the last meeting. And then the marketing and outreach services vendor, of course, we don't know who that is. We are currently going through that process. We estimate that the board will ratify it at the December meeting. The BOE will approve it in January, and that one is expected to expire in December of 2014, as are the consulting and actuarial services. And then finally on the board calendar, you can see where we're at. The only thing that really is slipped on there at this point is the review and approve the plan for risk adjustment and reinsurance. One thing that I do need to add that is not here for January, what we'd like to do, we'll have to add probably a workshop for December, or we'll add a workshop for the regulations that we just considered. Either we can do a workshop among just with staff if it's publicly noticed, or the board can do it. So I guess we should talk about that and whether or not we want to do that at the December meeting. But then once we adopt the regulations in January, it was our intent to go straight into the actually adopting the fees in that January meeting as well. And that pretty much wraps up the report from the executive director.
Thank you, Mr. Hager. If I might go back to the second workshop that we're talking about, and Mr. Belcourt, maybe you can help us with this a little bit. I'm fairly familiar with the regulatory process, and it does not always require the full board participating in it. But that would be the pleasure of the board if they want the workshop at a full board meeting. And so I guess what I'd like to do is maybe open it up for discussion with board members right now to see if they want to create maybe a subcommittee to move the second workshop along, or do you want to bring it back to the December meeting and continue to participate as a full board in that workshop? So I'll open that up for discussion with members.
Madam Chair, this is Leslie John.
Ms. Johnstone?
Thank you. As one board member, I would prefer if we bring it back at the December meeting for the workshop.
Okay. Thank you. Is there any objection, or Ms. Kerr?
I've participated in regulatory proceedings before, and it seems to me a little bit easier if we have a proposed version that some of the board members have gone through. I like the subcommittee process, and certainly bringing it back to the board so they can review it and give their input as well. But that way, if there's grammatical stuff or ways that we can finesse the language, such as Ms. Johnstone's comment earlier about whether or not we should have an additional subpart of a particular regulation part, I think it'd be a lot easier if you finesse the language when we have time to think about it, rather than at a full board meeting. But that's just my thought on it.
Any other comments from board members? Well, we've got a split decision on that.
Madam Chairman LaVon Lewis.
Yeah.
It seems that from the discussion we've had so far that we are recommending, or we are suggesting that it come back to the full board, but that a subcommittee review it prior to its coming back to the full board. Is that? Well, at least that's what I'm hearing.
Okay.
Madam Chair, I think
let me
Lynn
make,
Atkins,
go ahead, Ms. Atkins.
just if we need to vote on something in January, it would seem that a subcommittee is going to have to meet in December anyway, and I just think it's going to be hard to schedule that, I would assume, other than the date we already have for the board meeting. So it might just be easier to have it at the board meeting anyway, just for timing. But
You know what? Why don't we do this? Let's hold on a decision on this, and then Ms. Atkins, if I can get together with you in the next day or so to find out how much time you think you want on that navigator issue, because we weren't sure if we were going to do a telephone meeting in December or call for a full meeting, you know, at LCB. But I would like your input on that before we make that decision, and we can incorporate this in that discussion as well.
And for the record, John Hager, just so that everybody's aware, the next board meeting, if it's not by phone in December, it will not be here. The Legislative Council Bureau is reserved fully for the legislature starting, I believe, December 1st. So we would have to find another location, but it's not impossible. We just wanted to make sure you know it's not going to be here in December.
Okay, thank you. All right, are there any other questions or comments on Mr. Hager's report? There being none, I'm going to close that agenda item, and we'll move on then to agenda item.
Madam Chair?
Yes. Sorry.
I'm sorry, I got
That's all right.
sidetracked. I just had one request of Mr. Hager. If the blueprint submission could be posted on the homepage of the exchange, rather in addition to in the report section under what's new, so that it's up front and center for a while.
We will do that.
And you don't have to look for it.
Great comment, Ms. Johnstone. Thank you. Any other comments? All right, we'll close agenda item 6 and go on to 7. And this is a solicitation for written comments on possible ways to mitigate churn. Mr. Hager?
For the record, John Hager, we provided this report here so that we just get the public aware that we would like to have comments prior to actually submitting the agenda and reports for the Plan Certification Committee meeting. There's no action required here. We just simply wanted to make sure the public was aware that we would like to have those comments as soon as possible so that we could consider the consequences of churn and continuity of care.
Do any members have questions regarding this issue before we close this agenda item?
Madam Chair, this is Leslie Johnstone.
Yes.
John, what you just said was regarding the impact of churn and what the report says is ways to mitigate churn. What are you really looking for from the public? And do you have a few examples? I'm curious if the public would know what to do to avoid churn in and by themselves.
For the record, John Hager, so many members of the public probably would not understand what exactly to do to mitigate churn. However, there are individuals from the insurance carriers, the insurance industry, some of the consumer advocate groups, some of the providers are concerned with it. It's actually mostly the providers that are actually concerned with this issue, and so we're looking for their input. Churn is any time a person changes health plans. Typically, we think of it going from Medicaid to a private insurer or vice versa. So it's that Medicaid to a QHP, but it also could be from the exchange to off the exchange, from the individual exchange to the small employer market or to the shop exchange. So anytime an individual changes coverage, that would really be churn. And then, so there's two concerns. Number one is the magnitude of churn, and number two is what it does to the individual. So the magnitude of churn is how many times a person moves between health plans, or how many people move between health plans. And so there are ways to mitigate that. For instance, if you could somehow require that if there's somebody is on Medicaid and they end up with an increase in income, maybe they can stay on Medicaid for a given amount of time. Now, that obviously increase costs to Medicaid, but that would potentially decrease churn. Or vice versa, if you're on a qualified health plan with an advanced premium tax credit, and your income falls by just a little bit, does it make sense to go on Medicaid or to stay on the QHP? So those would be ways to mitigate the magnitude of churn. Then the other part of that is what it does to the individual. So if you're changing carriers and you're in the middle of an episode of care, or if you have a chronic condition, you currently have a certain set of providers. If suddenly you are on a qualified health plan or another health plan that doesn't have those providers, then you could end up having to go through the whole process again with new providers. You might have to have new pre-authorizations for surgeries and stuff like that. So not only are we looking at ways that could help the enrollment changes, but also we're looking at potential ways that transfers the information from an episode of care to a new set of doctors potentially, or to a carrier to help with pre-authorizations, or we use a plan that moves a person while the plan changes. They're under the same carrier. There's a lot of different ways that you can deal with it, and we're hoping that we can get some information from the public to help us come up with a recommendation if it's appropriate for Nevada.
Thank you.
Do we have any other questions or comment regarding churn? All right, we'll go ahead and close agenda item 7 and move on to 8, which is the Navigator and Outreach Specialist budget.
Is Mr. Bowden available for this item?
Yes. For the record, C.J. Bowden. We're here today with this report to discuss the information regarding usage, actual budgets, and proposed budgets of navigators and outreach specialists in the Silver State Exchange. At the last board meeting, after looking at the navigator, producer, and outreach specialist plan, board members had many concerns and questions about the budgets that were proposed for navigators and outreach specialists. Staff was tasked to go back and look at the different usage patterns of navigators and provide some proposed budgets or changes to budgets for navigators and outreach specialists. The first thing we wanted to do is look at anything historical, and as navigators are brand new to the ACA and to the insurance market, there really isn't a lot of historical data to go upon. Through research, staff was able to come up with 2 reports. One was by PricewaterhouseCoopers, and PricewaterhouseCoopers asked consumers, who will you work with to buy health insurance through an exchange? The answers to that are in Figure 1 on page 2 of the report, and if you don't have it in color, the answers were 36% of consumers said that they would go to a community resource center, a social worker, or someone to help them at that point. So the PricewaterhouseCoopers felt that 36% of the population would use a navigator-type agency to get help. The second study was from the Washington State Health Benefit Exchange. They surveyed 570 individuals that were eligible for the exchange and found that 3 out of 10 of those people, or 30%, who would require assistance wanted that assistance to be provided in person. How do we apply that to the exchange? Of our population, we have 145,000 people that we're looking to enroll in the first open enrollment period from October 1st until October 1st, 2013 to March 31st, 2014. Of those 145,000 people, 3,000 are expected to be employees, and the remaining 142,000 are expected to be individuals or families. If we assume the average family size is 1.3 family members per household, it is expected there will be 109,000 individual/family people that need help with for enrollment in the exchange. If we apply a 35% ratio to that 109,000 people, we come up with 38,000 consumers that would be likely to need or to use a navigator and look for assistance from a navigator during the first open enrollment. moving from there, if we have 38,000 consumers out there that will need the help of a navigator, how much time will they spend with a navigator? The staff surveyed many different people, including the local CHIP agencies, Medicaid agencies in different states, and different producers around this state and California to ascertain how many hours or the average amount of time that a person would need to spend with someone to sit down and enroll themselves or their family in a health insurance product. The average came out about 90% of the people said it takes between 1 and 2 hours, somewhere in there. About 90% of the answers were in there. For this report, staff is looking at an average time of 1.5 hours to enroll a person or family in health insurance coverage. We look at that 1.5 hours because a single person would take a little bit less time. A family is going to take a little bit more time. We wanted to bring it right into the middle for the purposes of this report. So that brings us to the number of navigators that will be required. If we have 38,000 individuals and families that are going to need a navigator to enroll in coverage at an average time of 1.5 hours, we have a total of 57,000 navigator hours required. If a navigator spends 7 hours a day enrolling consumers in health plans, it'll take 8,100 days for a single navigator to accomplish this. We have 129 working days in the first open enrollment period, so if we divide that out, we come to a requirement of 63 individual navigator persons to accomplish this, working 7 hours a day. If we look at other states out there, we have very, very limited information. There are only 3 states at the time that we did this research that have published any financial documentation on what they're going to do with their navigator or in-person assistance budgets, and Nevada is one of those. The other 2 were Arkansas and California. Arkansas has a in-person assistance program because they are a partnership exchange. They're not a state-based exchange, so they're using an in-person assisters program. They made the assumption that they're going to pay these people $12 an hour, and that did not include any upcharge for benefits or taxes or other employment costs, but they assumed $12 per hour for their in-person assistance. The reason they went with in-person assistance is because those funds can come from federal grant funding. Navigator funds cannot come from federal grant funding. They have to come from operations of the exchange. If we take that and extrapolate Arkansas's number and add in the taxes, benefits, and other employment costs, we come to about $16 per hour for those employees. If we look at California's model, California is going to pay navigators on a per enrollment basis. They've decided to pay $58 per person enrolled in the exchange to a navigator. They're not going to pay for retention of that person. They're just going to pay for the initial enrollment. That $58 figure was brought about by the fact they assumed a navigator with supervision, overhead, and labor expenses would cost an estimated $54,000 per year. It may be higher or lower than actual costs because different entities vary in their organizational structure and staffing structures. But they could, if they could put an estimated 4 applications per day or 940 applications annually, an average of $58 per application would fully cover their cost of enrollment. They're moving forward with this, and we're going to use those figures a little bit later in this report. Illinois did not give any financial numbers, but they are looking at the same plan that Nevada put forward in their Navigator Producer and Outreach Specialist plan by using block grants to pay for navigators. They're not going to pay per enrollment, and they're not going to use in-person assistance, but they're going to use a block grant to provide organizations monies to hire people to go out and do navigator duties. If we look at the Silver State Health Insurance Exchange and the implications of the research that we've done, we can look at our navigators and look at the budget that was approved when the Finance and Sustainability Plan. From September 1st, 2013 to December 31st, 2013, we had $285,000 budgeted. The next year, January 1st through December 31st, 2014, there was $380,000, and every year thereafter there was $380,000 scheduled and budgeted for navigators. If we use the assumptions that Arkansas used, paying individuals $12 an hour, upgrading that to $16 an hour to cover administrative costs to act as navigators, the Silver State Exchange would require approximately $925,000 in navigator funding for the first open enrollment period, that first 6 months. If the exchange uses the assumptions California used, paying individuals $26 an hour, the exchange would require $1.5 million in navigator funding for the first open enrollment period. That $26 an hour comes from the $54,000 that California looked at as an average cost, dividing that out by the 2,080 hours per working year. The current Exchange Navigator Plan addresses compensation in the form of competitive grants. Staff never looked at providing full-time employment for navigators because those entities that would be approached to be navigators would be entities that already have presentations or functions that they're providing in the community, and this navigator duty would benefit that or be an add-on to what they're currently doing. So staff didn't propose to put full-time wages in there. We looked at different grants when looking at the Navigator program to maybe provide computer equipment, travel time, space rental for presentations, those type of things in our original Navigator plan. Entities that apply for the grants must be entities that have existing relationships that are with groups that are difficult to reach or have different cultural and linguistic requirements. All funding from navigators must be derived from operations of the exchange or increasing the per person per month fee so that we have monies to give out in grants to navigators. In the exchange, the outreach specialists were approved in the Finance and Sustainability Plan at $75,000 for the first 3 months, an additional $35,000 for the next 3 months of open enrollment, or a total of $110,000 for the first open enrollment period. If we look at the exchange paying $16 per hour for outreach specialists, the first open enrollment period, we would have approximately 6,800 hours of presentation and outreach time devoted by outreach specialists. The second open enrollment period, we would have about 5,500 hours of presentation and in-person in-person presentation time. The exchange marketing and outreach campaign envisions creating partnerships between producers and outreach specialists. Producers could attend the functions with outreach specialists to help those attending enroll in health care coverage. This partnership, we already have a very strong producer base in the state of Nevada, and in the marketing plan it was envisioned that they could team with outreach specialists and be there. If a person wanted to sign up after hearing the presentation, they could ask questions, get their questions answered, and sign up for coverage at that time, since outreach specialists cannot facilitate enrollment. The exchange has also allocated an additional $200,000 for outreach and education efforts specifically targeting Nevada's federally recognized tribes. This is outside of the budgets that we have. This is in addition to. In conclusion, consumers looking to purchase health insurance on the exchange will require varying levels of assistance and education. To facilitate the exchange's goal of enrolling 142,000 individuals, it's actually 145, minus the 3,000 that will be employees through the shop side. That gives us 142,000 in the first open enrollment period. We must have a robust outreach plan and a budget in place. The exchange will have to use all the tools available, including advertising, outreach efforts, producers, and navigators to ensure consumers have access to the type of assistance they need. As exchange enrollment increases, there will be less of a population for navigators to serve. As we bring down the uninsured rate, there will be less people needing navigator services throughout time, so we can actually probably look at a decreasing budget over time in the navigator area. At this point, I would be happy to answer any questions that any of the board members may have, or if it is the board's pleasure, I can move on into some of the options that staff came up with when we looked at funding options.
Do any of the members have questions for CJ on his presentation on the research?
Madam Chair?
Yes.
This is Leslie Johnstone.
Yes.
I would just like to compliment staff on the methodology, how they put this together. What is probably a hard question to answer, but I wonder if there's any estimate of the enrollment activity, the split, what percentage of the population do we think navigators will end up enrolling versus what percentage do we think the brokers will end up enrolling?
On the first page, let's go back to that graph. It would be page 2 of the report. On page 2, it says that approximately 18% of the people surveyed would use an insurance agent or broker, and 36% would use a community resource center. This is off the PricewaterhouseCoopers survey.
Okay, thank you. So with that, then the navigator hours and FTEs that we think that we got to in this methodology is strictly off of the 1/3 of the population from the Pricewaterhouse study using Community Resource Center?
That is correct.
All right, thank you.
Yes,
Madam Chair, Lynn Atkins.
Oh, one question here.
Yes.
From Mr. Mollenkamp.
No, just a kind of a quick logistical question. So I know we have the eligibility engine and we have the eligibility workers within Mike's shop, within DHHS, and then we have these navigators. How do they interface with one another? How do they get to a navigator or into the eligibility workers within Mike's system? And then my second question is just logistically, just more for my information. Where do these navigators work? Do we provide an office, or do they work on their own, or how does that work?
For the record, CJ Bowden. Currently, the staff at DWSS will assist people that walk into their offices, and that will use that eligibility staff or the DWSS caseworkers to sign up people that are looking for insurance. They may come in not knowing what type of program they're eligible for. They can walk in and look at Medicaid, and if they're not eligible for Medicaid, they can be put directly into the exchange because we have one entry system as of now. Or if they're eligible for, they believe they're eligible for the exchange, they can go right into Medicaid at that walk-in point. That's where the DWSS staff would be used. We also have our customer call center where the people can call in. But the navigator portion of it, the way it's currently set in the navigator producer and outreach specialist plan is competitive grants would be given to navigator entities, and they would either have a brick and mortar shop or the ability to travel with a laptop computer, give presentations, give education, and sign people up at that point. Outreach specialists, on the other hand, can only give presentations. They're not going to be certified to enroll people. So the difference is in the funding. To be a navigator, you must receive grant funding from the exchange. To be an outreach specialist, you can be paid by the exchange to educate and give presentations.
So my I guess question, and I'm not sure it's a concern, my question is there going to be overlap here? Are we going to essentially be paying two people for essentially enrolling the same person? And I just want to make sure that however we dial it in, we're not setting ourselves up for a situation where we have a navigator getting paid for the work that the welfare division does, or vice versa. And I'm not sure how that handoff, how smooth that handoff would be.
For the record, John Hager. So we are certainly concerned about the handoff and making sure that goes smoothly. Our goal is to provide basically any way you come in, you can get to the service you need. So you could go to the web portal on your own, and you enter all your information, and you're eligible for a qualified health plan, and off you go. Or we say we think you're eligible for Medicaid, and we shoot you off to Medicaid for the determination by the Medicaid staff. Similarly, you could call into the call center staff, the exchange call center, and they will go through the process of getting your information and determining whether you're eligible for a qualified health plan, the advanced premium tax credit. And it could be that after you get that information, you know what, you're eligible for Medicaid, or it appears you're eligible for Medicaid. There's a bunch of different questions that have to be asked at that point, and off they go to Medicaid. Same thing would happen with the navigator. They would be allowed to enroll you in, to facilitate the enrollment, to be right there next to you as you enroll in a qualified health plan. But if they determine, if the web portal comes back and says you're Medicaid eligible, or we think you're Medicaid eligible, at that point they would have to hand you off to welfare, and there'll be at that point again a bunch of different questions that will continue the eligibility process. There is some overlap. We are working closely with welfare and Medicaid to make sure that we provide the services that are appropriate, that the cost allocation is done appropriately, and that we're not double, we're not working people double for the same thing. Keep in mind for the navigators, they're not going to be paid, or we had not intended that they be paid on a per enrollment basis, but rather a grant basis to do what they need to do to enroll people. And when they get to the point, the training would be that when they get to the point where they're Medicaid eligible, they would send them to welfare at that point to get the rest of the questions answered. The navigators should not be enrolling people in Medicare, but Medicaid. They should know the rules well enough to say when somebody should go to welfare to get that enrollment. So yes, there is some overlap, and we are working as closely as we can with our sister agencies and our vendors to make sure that that is minimized.
Any other questions?
Lynn Atkins for the record.
Yes, Lynn.
I also want to first say thank you to staff for putting this together, because I think this is exactly what we needed to really clearly see what may be on the horizon. So on figure 1 on page 2 of the report, what I find one thing just interesting, and then I wanted to ask a question about something else. It's showing a really, really small percentage of the people that think they can do it online by themselves. So this is just showing 3%, which is teeny, and obviously we'll have a long way to go to get that number up. And understanding these are just a projection from one report, I get that. But the 19% of the folks who aren't sure how they might get into it, are we not going to consider them that they're going to either fall in that they're going to need help in some way, and shouldn't we include, 20% is a large number of people that we're kind of avoiding at the moment, and I'm wondering how many of them are going to fall into the needing assistance by a navigator, or how many of them are going to be calling in the center. And I'm assuming that 24% are the people that we're talking about are calling Xerox, correct?
For the record, CJ Bowden. Yes, for this report, we did not put in any of that 19% that was off to the side. We looked at just the 36% that they're likely to use a navigator source. If we were to extrapolate that, we could take roughly a quarter of that and add it to the navigator portion if you divide it out over the other 4 areas of those people that aren't sure what they're going to use. So about another 5% at that point. And if you look at the 2 studies, the staff tried to err on the large side. We had one that reported about 30%, and we had one at 36%, so we took the higher of the 2 and rounded it at 35% for easier math.
Does that address your question, Lynn?
Yes, so I think when we get to the options, I guess we'll have to have a discussion about whether we want to increase the numbers to add some of those folks in.
Okay. Why don't we move ahead then to the funding options then? CJ, if you'll proceed with your report, please.
Thank you, Madam Chair. Again, for the record, CJ Bowden. Staff came up with a few different funding options that could be used to develop an appropriate navigator and outreach specialist budget for the exchange. The first option would be to leave the funding amounts as they are for both navigators and outreach specialists. If you take the $16 per hour figure, the navigators would have about 23,000 hours of assistance If you looked at $26 per hour, that would give about 14,500 hours of navigator assistance the way the budget is currently set. Option number 2 would be to increase navigator funding to $925,000 for the first open enrollment period. That would mirror the Arkansas in-person assistance budget of paying individuals $16 an hour to assist with enrollment. The additional $543,000 would require the exchange to raise the per person per month fee by 31 cents to accomplish that. In that scenario, the outreach specialist funding would remain the same. It wouldn't change. Option number 3 would be increase the navigator funding to $1.5 million for the first open enrollment period to mirror the California budget of paying full-time individuals $26 an hour to assist with enrollment. This additional $1.1 million would require the exchange to raise the per person per month fee by 64 cents. Outreach specialist funding in this option would also remain the same. Option number 4 would be to keep the navigator budget as it is at $380,000 for the first open enrollment period and increase the outreach specialist budget to $925,000 for the first open enrollment period. This would allow the exchange to pay for approximately 57,000 hours of in-person education. This correlates to 84 outreach specialists working 7 hours per day during the 129 working days of the first open enrollment. Each outreach specialist could be teamed up with a producer to facilitate enrollment. This option will allow consumers to have more, let's strike all, but more of their questions regarding insurance answered because producers can give more information than navigators can. Federal grant funding is available for this option and would not cause a change in the per person per month fee. Option number 5 is almost exactly the same, except it raises the outreach specialist budget to $1.5 million to mirror the California payment methodology. Again, federal grant funding would take care of all of the increases in option number 5. And lastly, option number 6 is a dual approach. Option number 6 would increase the navigator funding to approximately $460,000 for the first open enrollment period. The additional $81,000 will require the exchange to raise a per person per month fee by 5 cents. We would also increase the outreach specialist funding to $460,000 for the first open enrollment period. This will allow the exchange to pay for approximately 28,000 additional in-person education hours, or 32 outreach specialists working 7 hours per day for the open enrollment period. These would be teamed or could be teamed with a producer to facilitate enrollment and enroll people, and it would not, that portion would not cause a change to the PMPM. In option 6, the only change would be caused by the increase in navigator funding, and that would increase the PMPM by 5 cents. Those are the options.
This is Ron Klein. May I ask a question, please?
Sure, Dr. Klein.
Yeah, please forgive me if I missed this because it's sometimes a little hard to follow just by phone. But my concern at the last meeting, sorry, hold on. There you go. My concern at the last meeting was we didn't allow for volunteer navigators or outreach specialists. That I didn't feel, although I do agree with increasing the budget, I felt there should be the option to allow for volunteer navigators and volunteer outreach specialists. Do these options consider that possibility?
For the record, C.J. Bowden. At this time, the ACA clearly states that to be a navigator in the system, you must receive a grant from the exchange. That grant amount could be as low as $1, but having purely volunteer and non-certified navigators out there is not an option under the ACA. All navigators must flow through the certification process and receive a grant of some amount from the exchange. On the outreach specialist side, the outreach specialists would be contract employees or employees of the exchange. So other groups could go out and educate but not facilitate any enrollment whatsoever.
Okay, so just to be clear, I have no problems with navigators and outreach specialists being certified. by the exchange. My primary concern was that we wouldn't have sufficient funds to fund all the navigators and outreach specialists that we would need. And as your survey from the consulting firm shows, many people will go to community specialists or to their community groups to get information on this. So I think that underscores the importance of having navigators and outreach specialists as part of community groups who may choose, who, as I mentioned last meeting, may choose to simply fund those individuals for the benefit of their own groups. So I guess I just want to make sure that certification is fine, and I understand that the dollar per year is fine as well. Just want to make sure that we include that option for community groups that have the resources to fund their own specialists and navigators and may not get a competitive grant from the exchange.
For the record, John Hager, we will make sure that all options are available. It will depend on the grant applications that we receive and the communication that we have with the outreach or the consumer advocate groups. But one of the things that the original budget contemplated was the use of services for very low dollar amounts, for instance, that dollar, or providing a low fee to, or a low amount to an advocate group that already does something that is similar to it to simply supplement and leverage their services. And that's what the original, and I guess it's option one is to not change anything. These other options increase the budget, assuming that that there is no volunteer or $1 amounts. That's not to say that we couldn't still use a group that is willing to do it for a very low fee, but this ensures that if there's nobody willing to do it for a very low fee, these prices or these budgets will help us cover those expenses. One thing to keep in mind on the options. While we use these dollar amounts, $16 and 20-something per hour, that doesn't mean that that's what we would pay a navigator. That is simply a basis for the budget, and so that we have a sound number to give the board to make a determination on what the board would like to do. So that's how we came up with these 6 options. We figured out how many hours we would need, and then the dollar amount. So the 6 options basically are broken down into leave it the way it is, use the Arkansas pay, use the California pay, put it all in Navigator, put it all in Outreach Specialist, or put it in equal amounts in the Outreach Specialist group and the Navigator group. Those are the 6 options that we presented. There are an infinite number of iterations that the board could choose. And then back to Ms. Etkin's point about the people that are not sure in Figure 1, that 36%, if you take out the not sure, is 44%. So if you assumed that the people that are not sure would purchase coverage in the same ratios that the remainder of the population did, 44% of the population would use a consumer community resource center, which we were saying would be the navigators. If you use 44%, that is a 27% increase on the overall budget compared to the 35% usage that we used. So if you want to use the 44% to take into account the not sure population, you would need to increase the total dollar amount of the budgets that are presented here by 27%.
Forgive me, just one other question, and I'm a little bit confused. I thought I heard earlier in the conversation that navigators could not be paid through ACA funds, and then there was something else I heard that said that navigators had to be paid through exchange funds. I'm a little confused about that. Who has to? How are navigators paid, and how must they be paid?
For the record, C.J. Bowden, the navigators can receive grants from the exchange, and they have to receive a grant from the exchange. The funding for those grants for navigators may not come from an ACA or Affordable Care Act grant from the federal government. Those monies that are given to the exchange for establishment cannot then be subgranted out to navigators. The navigators need to be paid from funds of the operations of the exchange. And that was put into law, and that's very detailed.
So the ACA specifically says that a navigator must be paid by the exchange?
Yes.
Okay, thank you.
Do we have any other questions?
I do. This is
Dr.
Cox, and I'm with Cox Insurance Services in Reno.
You know what? I'm sorry. This is a board discussion. I'll open it up for public comment at a later time. So, do we have any board members that have questions? Yes, Dr. Ford.
This is Dr. Ford. I'm just following up on Dr. Klein's question. So, if navigators must be funded by grants from the exchange, outreach specialists are the exact opposite. They're paid through federal funds and would not affect per member per month fees.
Yes, that is correct.
So this is my question. So if the intention of the board and the exchange is to keep the per member per month numbers down so we can be competitive with the out of exchange insurance offerings, wouldn't it make more sense to use the federal funds for outreach specialists rather than ramping up our per member per month?
Madam Chairman, LaVon Lewis.
Ms. Lewis.
Yes, I think that the reason we were interested in having navigators and increasing, even though I was chairman of the committee that put in the amount for the budget for navigators, after further review, realized that is not sufficient. The reason for having and suggesting an increase in the navigator funding so that community organizations who are located in the areas where many of the uninsured reside would be available to provide the assistance necessary for them to become enrolled in the exchange products. And while I am certainly supportive of getting as much as we can from the federal government to support the enrollment of the uninsured, I think we still have to have an increase in the navigator funding. Therefore, I would kind of support maybe item number 6.
Ms. Kerr?
Lynn Atkins, Madam Chair.
Yes, Ms. Atkins.
Yeah, and I guess I see two issues. The outreach specialists, number one, can't enroll anybody. So at least that's the definition that is being proposed that we will be voting on at the next meeting. So they can do a very limited amount. However, I like the idea that if they can partner with producers and brokers, I think that's great. And I do think that since that can come from federal funding, and we've received, $75 million, I would think that a large amount of money that could go to the outreach specialists, especially for the open enrollment period, would be a great idea. But we also are going to need navigators helping people enroll in the areas that we've discussed for folks that have never had insurance before. So, I think we need probably a combination of some of these suggestions. But I definitely think with the federal funding, we should try and use, enough of it for outreach specialists and then figure out what the number we need for navigators.
Ms. Kerr?
Given the competing concerns we've seen of trying to spend as little state dollars or per member per month fees, but at the same time realizing that the navigators play an important role, I really do think the split approach is a good idea of item 6.
I guess
Madam
I would.
Chair.
Yes, Ms. Johnstone.
I'll just provide my commentary on this topic. I think that the navigators, we're not talking about assuming that all of the enrollees go to either brokers or navigators. This is the best estimate that we have about what the split will be. And so I think that at a minimum, on the amount of time that is budgeted for navigators, should at least mirror this model. And I would suggest going, for conservation's sake on what the cost will be, the lower of the two for navigators. And then on the outreach specialist, go with the recommendation that's in option 6. One thing that bothers me a little bit about the wording in the report is that we're teaming up the outreach specialists just with the producers. Then the outreach specialists are going to have to support the entire system, and then either the navigators or the producers are going to pick up the enrollee depending on the enrollee's preference. And so my recommendation would be err on the high side of the resources needed for navigators, hoping that it comes in at the lower cost, using the Arkansas basis for coming up with the cost for navigators, and going with the recommendation on number 6 for the outreach specialist.
All right. Ms. Johnstone, can you go over that again? Well, I just want to make sure I understand what your comments were. So if we went to option number 6, you're not looking at the first paragraph, which is only one sentence. You're looking at increase the outreach specialist to $461,000 for the first enrollment period. Is that correct?
Madam Chair, I wasn't ready to make a recommendation. My main point was to go with the navigator resource estimate, and that is in option number 2.
Okay.
And then on the outreach specialist, I said number 6, but I think that's probably up for discussion since that's coming out of the federal grant. We may have much more latitude on that. And my overarching comment on this is for this first year, I think we ought to err on the side of having too many people out there to help the potential enrollees. And I do think it's a fair estimate that in the out years, maybe this navigator budget won't have to be as high as it was originally estimated. But we do not want to underestimate the amount of time it's going to take this first cycle.
Madam Chair, Lynn Atkins, I would agree with those comments, and I think using the $900 and some odd $1,000 for the navigators and the higher number for the outreach specialists. I think in item number 5, it's at $1.5 million. I would say, though, we have not yet voted on the definitions. That was what kind of got deferred at the last meeting. I don't know if there is the appetite or possibility of just ever so slightly, and I don't know what that means yet, but ever so slightly expanding the outreach specialist capabilities just during the open enrollment period to be able to really leverage these federal dollars to do more than a presentation. And I don't know where that is. And I think our subcommittee had been discussing these definitions since last summer before. I think right when we started discussing them, the outreach specialist funding kind of came through. But now that we're really starting to look at the dollars and cents, I'm just wondering if there's something we could do with that definition to give them a little bit more capability to help get people enrolled. So there's probably not an appetite for that, but I would suggest the higher dollar amount for the outreach specialist since it's federal funding.
Ms. Atkins, since this is your subcommittee that you're chairing on this, do you want to take this report under consideration and bring it back at the same time as you bring back your recommendations from last meeting that we put on hold so that we could see this report?
That might not be a bad idea, so we could see it all together as one. I think my concern is that I really, really would love to get that done in December, and I understand that the meeting's been, I think, reduced down to about an hour. If I can go off topic for a moment, my subcommittee has been working so hard this whole year, and very few of our recommendations that we've been spending months and months and months on, they've been deferred and delayed. So I think that might be a good big picture plan, so we could all see what the definitions are, what everyone's going to do, what the budget amounts are. Again, but my preference would really be to try and get this done in December.
I asked Mr. Hager earlier today, I saw how short the meeting in December was, and he was, I'm certain, doing that as an accommodation to the board that's been working hard too. But I told him I would defer to you on how much time you wanted in December, and then we'd schedule that meeting based on what you felt you needed to bring forth those recommendations. And then now we're adding the workshop to it too, so I think we're back to a full schedule is my guess. But if Ms. Atkins, if that sounds like a more reasonable approach, is to take this study under consideration and blend it with your recommendations and then bring back both of them for approval in December, I'm fine with that if the rest of the members are.
That's fine with me if it's okay with the board.
Do we have any objection?
I would support that. I think it makes sense.
Does anyone object?
Staff would appreciate a review of the recommendation. So are we? I just so that we can incorporate it properly in the plan for navigators, producers, and outreach specialists. Does that mean increasing navigator funding to $923,000 and increasing outreach specialist funding to the $1.5 million, or and see what we can do as far as enrollment for outreach specialists? Is that?
Madam Chair, this is Leslie Johnstone. I think that was the working discussion, I'll call it, intended for the committee to go through next week.
This is Dr. Ford. Isn't that 900,000 number actually low, considering that CJ here is crunching numbers on the higher? And he's sitting here crunching all these numbers again. So actually the numbers are actually even higher because we cut the pie again?
So we would have to increase the numbers by 27%.
I think what I was hearing, and Ms. Atkins and Ms. Johnstone, correct me, is that you're suggesting that staff review the navigator funding at the higher levels and also try and capitalize as much as we can on the outreach specialists so that we can take advantage of any federal funding that's available to us. And in doing all of that, I think everyone's very conscious about the per member per month fee. Does that restate it fairly well?
Yes, Madam Chair. And I think what we had talked about the last meeting, that if there are not enough boots on the ground at the beginning and people get frustrated and leave, it won't kind of matter that we saved everybody 20 cents per month. I mean, so I think I think at least that's the discussion that I'm hearing and understanding, is that we need to, if anything, overstaff at the beginning, be able to pull back because it will be too hard to catch up.
And the last question I have, Madam Chair, the previous board item was to defer and get more information on the budget and then bring it back to the board. I thought we were bringing it back at the December board meeting. Did we want to bring this back to the Consumer Assistance Committee meeting that Ms. Johnstone had indicated that we do this next week, or do we come up with this package and simply bring it back to the board?
John and Madam Chair, I thought we were going to bring all of this together to the Consumer Assistance Committee meeting next week so we could take a look at this entire package with all the definitions, all the new reports, look at the funding, and then bring it back to the board as one package for December.
We will do that. And Madam Consumer Assistance Chair, if you could be watching your email tonight to approve the agenda so we can post it first thing in the morning. Thank you.
All right. Do we have any other comments or discussion on agenda item 8? If not, I'm going to, I was actually
I'm sure you might have had someone on the phone.
Does the board want to open up for public comment now on this particular issue instead of waiting to the end of the agenda? Okay, I'm seeing nods. So, all right, I'm going to open it up for public comment. We had someone on the phone that was trying to make comment some time ago. If that person's still on the line, now is your opportunity. Please identify yourself for the record. Okay, here in Carson City.
Good afternoon. My name for the record is Elisa Cafrota with Nevada Advocates for Planned Parenthood Affiliates. And sorry I was not able to provide written comment on this. I was recovering from the election. Still am. So I will try and do that for the consumer assistance meeting based on the conversation here. Just two comments that I know that you've just seen the report, and there's a lot of thinking going into this process. The calculations are sort of amazing and a very helpful start for budgeting purposes. The idea that 100,000 people are just going to show up and do an hour and a half with a navigator or an insurance broker and all sign up is probably not anything like what the actual process is going to look like. I've always sort of envisioned that there would be a block grant aspect to this process, and that was the original description. So one of my comments is I would like you to consider maybe keeping a portion of the funding in a block grant format. If we think about organizations like the health centers that Planned Parenthood has around the state, I could envision us incorporating this education piece into our work with all of our clients, not only during the open enrollment period, but whenever we see these clients, which is typically twice a year, because it's going to take a little bit of time to introduce them to the idea and then sort of give them the information about why they should actually show up and do the hour and a half during the open enrollment period. So I would ask that you consider possibly keeping that less of a just hire staff to sign people up and more maybe some innovative education processes. The other thing that I think would be very helpful is thinking about integrating the planning for this, or at least maybe having a workshop with the firm that you hire to do the marketing and outreach, because whatever they do, whether it's commercials or hiring people to walk neighborhoods, or I'm not sure exactly what that's going to look like. I know there's a large contract out there. That piece will definitely need to be integrated with the, particularly the navigator piece, because those ads or that outreach is going to hit, and the navigators need to be ready to sit down and have that conversation. So possibly something that could be included in the marketing contract is some kind of strategic planning and integration with the navigators and specialists, outreach specialists, to make sure that everybody's sort of on the same page in terms of timing and process, so that when the ads go out, there's some place for them to go, since a large number of folks just won't go to the website, it looks like, and we'll need to have a lot of work walking through the process. So those are my initial thoughts on it, and we'll write some more up for the next meeting, but thank you.
Thank you very much. Any other comments here in Carson City?
Thank you, Madam Chair. For the record, Adam Plain, Nevada Division of Insurance. As frequent viewers of the board and committee know, I like to throw curveballs. Just another one for your consideration for the committee meeting next week and future board meetings. In the discussion of the outreach specialist portion of the budget, it's been couched, at least temporarily, with that pairing of the licensed producer to kind of complete
Attention, please. Your meeting will be disconnected in 30 minutes.
To complete the cycle, just as a concern that will require some research. Such a pairing may subject the exchange or the state.
Madam Chair. I'm sorry,
Yes,
we lost
Miss-
sound for about 30 seconds there. Could Adam start back a minute
okay.
or two into his?
It's probably the alert telling us we've got 30 minutes, and just I've got notes up here. They'll do it again at 4:15. So, Mr. Plain, can you start again, please?
Certainly, just as a curveball for your consideration for the future discussion with the outreach specialists and the budget being paired with licensed producers, I have at least a nagging concern that without proper legal research, we may inadvertently expose the exchange or the state to vicarious liability for the actions of producers paired explicitly with outreach specialists who are endorsed by the state of Nevada. So just as a word of advice, that may be something we want to look into. It may be the sky is falling and I'm completely off base, but just as a topic for discussion.
I'd rather have the discussion than get blown aside somewhere and not have discussed it. So thank you. I appreciate that.
We'll work with the Division of Insurance to create the proper program.
All right. Is there anyone in Las Vegas that wishes public comment on this navigator and outreach specialist issue?
No, Madam Chair.
Okay, and I'll try it one more time on the phone. Is there anyone on the phone that wishes to participate in that public discussion? Okay, thank you. We'll close that discussion on agenda item number 8. I'm going to ask the board its pleasure, since we've got 30 minutes and another public comment period. Do you want to hold off on agenda item number 9 and bring it back in December, or do we want to plug through for till about 4:15?
I think we should
Madam
hold off
Chair, are
on
there
it.
highlights in item 9 that John could provide instead of going through the entire report?
I can go as quickly as succinctly as possible.
Yes, and Dr. Klein, you're still on the line?
Yes, I'm still here.
Okay. You know, I'm going to ask John to maybe summarize what we did at plan certification because of the shortness of time. But I would ask you at any time, since you're vice chair of this, along with me on this committee, to please interject any of your thoughts or comments as we're going through this summary.
For the record,
Thank you. I will let John go and then I'll comment.
Thank you.
For the record, John Hager. So item number 9 consists completely of plan certification and management committee recommendations. The first recommendation was that all plan certification policies be formally reviewed in the spring of 2015. There were concerns from the carriers about the ability to have proper information from the health plans by the spring of 2015. We would only have the first year of data, which will likely be skewed because of all of the changes happening to the market. It will be difficult to know what's going to happen. Rates will probably not truly be normalized until 2015 or 2016, probably more like 2016. So it'll be, or even 2017. It will be difficult to have good rate information by the spring of 2015. The other side of that, though, is there is a lead time required to implement policies so that carriers have enough time to implement them for a plan year. So something that's reviewed and a policy is created in spring and then summer of 2015 would not really take effect until 2017, because by summer of 2015 it's too late to affect calendar year 2016. Staff has committed to ongoing continuous review of policies and market conditions with the assistance of the Division of Insurance, making sure that the things that we do are proper for the citizens of Nevada. So we will continue to monitor the market and the policies, and as we get information from individuals, consumers, insurance companies that leads us to believe that there should be a change to our policies, we will bring that forward to the board. And there are also different times in which you should review various policies. For instance, if consumers are confused by the plans that are offered in the exchange, we can figure that out after the first enrollment rather than waiting a full year. However, if we want to consider going from an open market facilitator to an active purchaser model, we really need some better data to get there. So that was the discussion about reviewing the policies and question number or item number A. Item number B has the Division of Insurance certified qualified health plans to be offered on the exchange, and then to, I'm sorry.
That's just keeping it at an open market, that if you...
I'm sorry, yes, basically so notwithstanding any requirement or limit to the contrary, any health plan that meets the requirement of the exchange, the Division of Insurance and the Affordable Care Act and its regulations will be certified as a qualified health plan. That simply reiterates the open market facility philosophy. Then items C and D allow the Division of Insurance to certify and then recertify on an annual basis. And then finally, item E has the exchange retaining the decertification processes of a qualified health plan. And so the question that has come up from outside of the exchange was, what condition would the exchange see that would be necessary to decertify a qualified health plan? The committee came up with if there is a network adequacy rule that says that they have to have a certain number of types of facilities, then and then they suddenly didn't, that the exchange could decertify them. The question then is whether or not you would want the exchange to decertify right then, or whether you would wait for them to finish out and you simply wouldn't renew or recertify. Typically, from my understanding, the only time the Division of Insurance actually pulls the ability of a carrier to provide insurance on the market is when they when there's a financial solvency issue. If there are network adequacy issues or other issues, they usually work with the carrier to help resolve that issue before drastic action is taken.
And I think basically item E is nothing more than saying that the exchange will keep that authority since the statute gives it to the exchange. The second part of that is that we felt at the committee level there that we probably needed to have regulations to help guide us through an administrative process for some in order to define what appeal rights there are, or if this could move up for judicial review, and that's where we needed the help of the Attorney General with that. So I think the recommendation is nothing more than saying that the exchange will keep that authority at this point in time, and we'll move forward at a later date with regulations to define the administrative procedure on it. And then, Dr. Klein, any further?
I'm right here. Hold on a second. Sorry. So my only thought, and I a couple comments. First, I think the conditions under which we might decertify a plan don't need to be defined at this time and might change over time. In addition to financial solvency and network adequacy, if we had a plan that we felt was not behaving properly towards its members or towards its physicians, we might choose as an exchange to decertify that plan because it wasn't operating under the principles that we've adopted. I sort of view the exchange as a good housekeeping seal of approval, and if we have plans that aren't doing their job properly, then I think the option needs to be there to decertify. So I really don't think we can define right now the exact conditions under which we would decertify a plan. The only comment I had in addition was I wanted to make sure that recommendation C and D, where we allow the Division of Insurance to certify and D, where we allow them to recertify, doesn't come in conflict with E, where we maintain the authority to decertify a plan, and that I would not want some kind of confusion to exist in the future where we've adopted C and D, and the Division of Insurance recertifies the plan, and for whatever reason we choose to decertify a plan and find that there's some conflict between the exchange and the Division of Insurance.
Thank you. We have some public comment here from the Division of Insurance. So.
Thank you, Madam Chair. Cliff King, Division of Insurance. And first and foremost, the Division of Insurance is a consumer protection agency, and it's our intent to protect consumers first and foremost, period. When we look at decertification, certification, recertification, any part of it, there's a number of issues that go in. Decertification might not be limited to solvency. It might be related to market behavior. The Division of Insurance actively reviews, does examinations of insurance carriers licensed to do business in the state on a regular basis. The normal basis is about every 5 years we do a market conduct examination as well as financial examination. When there's a need, meaning consumer complaints or some other activity going on that warrants examination, it's conducted much more frequently than that. If we find something on a market conduct examination, many times that information is confidential in nature. So we would not be at liberty to share why we would take particular action against a carrier. Sometimes those types of actions result in an agreement, a consent to fine, if you will, where the carrier agrees not to continue their behaviors and they pay a fine, but they've not admitted any wrongdoing. That is quite common, and it happens all across the country. However, we do get behaviors changed as a result of such a finding or such an examination. So I would just caution that sometimes there would be reasons for us to take action without being able to tell you why. And it's because it would be confidential in nature. Finally, we also had the Memorandum of Understanding where the Business and Industry Division of Insurance, Department of Health and Human Services, and the Exchange had a Memorandum of Understanding that, frankly, our portion of it was reviewed by the governor and approved, and I believe that fell into our ball court. And so we would just take a look at that as well. I'm not suggesting there's any conflict now or ever will be between the Division of Insurance or the Exchange, because frankly the Exchange wants to have a very healthy competitive marketplace. The Division also wants a very healthy competitive marketplace. So I think we have common grounds where we work together as opposed to against each other.
No, and I think history demonstrates that, so thank you. At this point, I don't know if we should move ahead with. I know we only have 15 minutes left on this, and Dr. Klein, I agree with you. We want to make sure that C and D are not in conflict with E, and then based on what Mr. King just said, I think we need to go back and look at that Memorandum of Understanding to see if we've already defined who does what in there. So I think my recommendation at this point is that we hold off and bring this back in December after we can get some of those clarifying facts. Oh, you've got it right there? Okay.
For the record, John Hager, so the Memorandum of Understanding, and it was reviewed by the board in September. It does have a line on there that says that the recertification, decertification of qualified health plans, that the Division of Insurance would take the lead and the Exchange would have input into it. My understanding was that this is the basis to start off, and it can obviously be updated if we need to. So it's up to the Exchange and the Division of Insurance to make to agree to change that if that's what we want to do. And certainly this memorandum of understanding was very broad, and there will be things that need to be nailed down. For instance, all of the certification and recertification processes, regardless of what we do for decertification, we will have to have a better understanding of what each entity will be doing. But certainly the starting point was that the Division of Insurance would recertify and decertify.
Attention, please. Your meeting will be disconnected in 15 minutes.
Can you hear us down in Las Vegas? Can you hear us in Las Vegas?
Yes. Lynn Atkins, may I ask one question?
Yeah, we've got 14 minutes.
Yeah, I just... Are you insinuating my questions take 14 minutes? No, I'm kidding.
No, I'm actually not. I want to make sure that I've got time to put public comment on before I adjourn.
Yeah, I hope it's a quick question, and if not, John can just say he'll answer it later. So on the policies being formally reviewed in the spring of 2015, was there contemplation that, one of the consultants would be tasked, in January of 2014 to watch, track, review, compile data ongoing? I can just imagine that winter 2014, someone is told, hey, we have a meeting coming up in spring 2015. Can you kind of gather data together? It would just seem to be a really great use of the consultants that they can track and watch whatever data the committee wants to review while it's happening instead of after the fact.
Lynn, I'll answer that because that was of great concern to Dr. Klein, and Dr. Klein can jump in. But it was our understanding that staff's going to be tracking this all the way along the line, and that, if we see anything that's unusual happening, we just, and Dr. Klein, you can state it better than I can, but you wanted to make sure that we had that review earlier than later so that we could have some input.
Thank you, Madam Chair. And my only point was that even though we understand that the data will be incomplete and preliminary in spring of 2015, there still will be data, and you don't just put your head in the sand for 2 years, since we're now in winter of 2012, so 2.5 years, and say, well, darn, the data's just incomplete. You're constantly reviewing what's happening so that you can take action if you need to, with appropriate caveats that the data is not complete. And especially with the lead time that John referred to, I think it's important that we look at this earlier rather than later. And that doesn't necessarily mean we would make any change. It just means that we pick up our head out of the sand and look at it and say, how are things going so far? That just seems like a fair, pretty normal thing to do.
Dr. Klein, would you object to us looking at recommendations 6, 7, and 8 in December, and my moving this agenda item so that we can get to public comment and adjourn before they shut us off?
Oh, that would be completely fine with me.
Okay. Thank you. Then we're going to delay action on the items under agenda item number 9, and we're at agenda item 10. Our next meeting date is December 13th. I think, Mr. Hager, you'll be getting back to us with a place and time, and I think we're probably best to schedule 1 o'clock.
Yeah, it might even have to be earlier.
Okay. And then, Ms. Atkins, I'll get back to you, and we'll coordinate on how much time you think your committee would like to have in its reporting at the board meeting.
Sounds great. Thank you.
Is there anything else that board members want to bring forward right now for possible discussion at December or at a later meeting? Okay, there being none. Oh, Mr.
Workshop? Where did the workshop go?
On the... Okay. All right, we'll close agenda item 10 and open up for public comment. Is there any additional public comment from Las Vegas?
No, Madam Chair.
Anything here in Carson City? Anyone on the telephone? We did it. We got 10 minutes to go. All right, with that, then I'll close public comment and call for the adjournment of the meeting. And I want to thank everyone for their review and preparation for the meeting, and thank all the public for joining us today. We'll look forward to seeing you at the workshop next week and at the board meeting December 13th. Thank you.